on the Public Health Emergency Operations Center, or PHEOC, Malaysia capacity in managing COVID-19. This is my outline of presentation. To begin with, I will talk briefly on the Incident Command System, or the ICS, so that we can have a look on its similarities and differences with the Incident Management System, or the IMS. The ICS is a standardized approach to the command, control, and coordination of emergency response, whereby responders from multiple agencies are put under one unified command. In Malaysia, the police is the incident commander at the scene. He or she will be assisted by a number of officers and personnel from different agencies, namely the Fire and Rescue Department, the Civil Defense, the Emergency Medical Services from the Ministry of Health hospitals, as well as from other relevant agencies. What happens at the scene in the field? The fire rescue personnel will size out the scene and they will establish what we call the disaster zones. The disaster zones will be divided into 3 zones. The red zone as the innermost zone, followed by the yellow zone, and then the green zone as the outermost layer of the disaster zone. The police commander will be stationed at what we call the on-scene command post in the yellow zone. So here you can see the organizational structure of the ICS in the field. At the very top is the incident commander. He or she will be assisted by a number of officers, namely the PIO, the Public Information Officer, the LO, the Liaison Officer, the Safety Officer, and maybe some other officers that the incident commander might appoint. And this managerial team, so-called, is further assisted by different sections, namely the operations, the planning, logistics, and finance and administrative section. And this section can be further divided into branches or divisions or units depending on the scale and complexity of the incident. So the ICS is flexible and scalable in modular form applied in the field. Now we look at the Incident Management System, or the IMS. The IMS is relatively new, first introduced by the WHO for the Public Health Emergency Operations Center, or the PHEOC, back in November 2015. So basically, the IMS is the management system applied at the ops room, or the PHEOC in this case, at the district, state, or national level, unlike the ICS that we just discussed, which is applied direct at the scene in the field. The National PHEOC for Malaysia is known as the National Crisis Preparedness and Response Center, or Cprc, which is manned under the Disease Control Division under the Ministry of Health Malaysia. So this is one of the photos of the Cprc Malaysia, whereby I was working with my ex-colleagues from the Ministry of Health Malaysia about a year ago. So here is the organizational structure of the IMS, which is similar to the ICS. But here at the top, we have the incident manager. He or she will be assisted by a number of officers, namely the LO, the PIO, the Safety Security Officer, and maybe some other officers as needed. Again, this managerial team will be further assisted by a number of sections, namely operations, plans, logistics, as well as finance and administrative section. And depending on the complexity of the event, it can be further divided into branches, divisions, and units. The main difference of the IMS is that it is applied at the national or state or the district level, which is much higher than the ICS, which is applied at the scene in the field. And the main functions of the different sections and units of the IMS are to ensure the smooth running of the PHEOC itself and to give support for the teams that are responding at the scene. This is the summary of the IMS structure and functions. So here the management team is very crucial in making decisions, in coordinating and mobilizing the resources at the scene. The planning section is responsible for evaluation of the situation. For example, for the risk assessment, it will be gathered and analyzed by the planning team for next action to be taken. The operation sections is supporting tactical application of resources. So this is the section that establishes the tactics and strategies and directs the operational resources to achieve the incident response objectives, or what we call the incident action plan, the IAP. The logistics section is responsible in acquiring and deploying resources. So in the aspect of procurement, distribution, maintenance, and so on, as well as providing the infrastructure support and services to the response staff is fall under this logistics section. And last but not least is the finance and administration section, which is responsible in tracking the expenditure, payments, and all other administrative services. Well, when I was still with the Ministry of Health Malaysia back then, myself and ex-colleagues, we had undergone a series of specific PHEOC training conducted by the US CDC Global Emergency Management Capacity Development Branch. So here is Peter, the main trainer, and he is assisted by a number of other trainers. Among others is Catherine. She's also almost with Peter whenever we had our training sessions. So we had 4 different workshops altogether conducted in Malaysia in the year 2018 and 2019. So basically, quite a number of us have been trained specifically in this PHEOC in applying different roles and tasks and responsibilities by different sections in accordance to the IMS organizational structure that I just showed to you. Just sharing some of the instances on how do we run the PHEOC. So here is the operational modes for the PHEOC to function. It is divided into 3 modes, what we call the watch mode, alert mode, and response mode. So during the peacetime, the watch mode is applied throughout the year. And we have a dedicated team or the watch staff that will monitor the situation. For example, that they will look at the trends of communicable diseases, and they will notify to their supervisor if the incident touches the epidemic level. The watch staff, also the ones that produce what we call the situational reports or the CTRAPs and the spot traps to be given to the supervisors and may be further analyzed by the team, say a team of epidemiologists. And if there is a concern of the events is pending outbreak or just past the epidemic level, then quickly the PHEOC will do the preliminary assessment. So basically the early risk assessment will be conducted here at the alert mode. And at the same time, the IAP or the Incident Action Plan is initiated, and the higher level of the organization starts preparing the specific team if the PHEOC needs to be activated on this specific event. And furthermore, if the event is really taking place, then the response mode will be activated. The incident manager will be appointed together with its relevant staff to man the different sections. Different units, okay? And the way the IM team being activated is depending on the specific event. So for example, if there is a specific outbreak, say a cholera outbreak, so a specific incident manager with its team will be activated just to man for that particular cholera outbreak. If at the same time another event is happening, say that there is a chemical incident happens somewhere in the country, then another team with its own incident manager, with its respective staff for their IMS for the chemical event will be activated. So that in one PHEOC, there can be more than one IMS structure to be activated depending on the number of different events that happens at that time. This is the Incident Action Plan or the IAP. So the purpose of IAP is to ensure the common goals among the response personnel. It provides direction for actions. It provides means of communication of the incident objectives and ensure the coordinated response. And this is the interface of the PHEOC in relevance to other AOCs. For Malaysia, we have 3 tiers, which is at the very bottom is the district level, then at the state level and the national level. So there are EOCs by different agencies at all these 3 levels. So the PHEOC has to communicate with other national EOCs manned by other agencies. So the National Cprc of the Ministry of Health Malaysia is the one that coordinating the COVID-19 public health response and supporting critical activities such as risk assessment, mobilization and distribution of personnel and material, and communications in an organized manner by applying the incident management system. The national CPRC is well supported by the state CPRCs across all the 13 states and federal territories, covering both West Malaysia and East Malaysia, as well as supported by all other EOCs by different government agencies. This is the picture of the Malaysian King visiting the National CPRC in Putrajaya on the 18th of March 2020, which was the date of the Malaysia first lockdown during the COVID-19 pandemic. Thank you.
Thank you, Dr. Badrul, for this excellent insight of how we manage the disaster. And now Dr. Badrul will take some questions from the audience. Questions will be displayed on the screen from Slido app. Yes, over to Jan here. I will ask Dr. Badrul regarding how does this management change in case of this pandemic COVID-19?
Sorry, say again, Dr. Sajan, your question?
How did this management of COVID-19 pandemic change your style of changes which has been brought from March 18th? How did this management take place?
All right, okay. Thank you very much, Dr. Sajan. Right. The PHEOC, during the peacetime, I would say, during the peacetime, we have the team that running the PHEOC. Yeah, I mentioned about the watch stuff, the watch mode, which is happening 24/7, 365 days a year. Yeah. But then whenever there is a specific incident, so obviously the COVID-19, so the specific IMS structure for COVID-19 is activated, all right? And if I recall, so when I was in the Ministry of Health Malaysia, actually we started monitoring this COVID-19 back in November, December 2019. So if you remember Wuhan in China, so already got suspected cases back then in November and December 2019. So actually we already alerted this IMS specific for the COVID-19. And obviously for Malaysia, our first case was diagnosed on 25th of January 2020. A China national, came to Malaysia through Singapore, right? With another close contacts. And even among the close contacts, there were 3 were tested to be positive. So initially, the team that ran the PHEOC was the same team that running the PHEOC during the peacetime because it was manageable, okay? But then obviously when the number of cases surged, increased in number, and then because the PHEOC, the CPRC Malaysia, actually manned under the sector, the Disaster Outbreak Crisis Emergency Sector, under the Disease Control Division, Ministry of Health Malaysia. But when the event scaled up, then we mobilized officers and staff from other sectors as well. Yeah, for example, from the surveillance sectors, from the international health sectors. Okay, but still within the same disease control division. But after some time, when it started, scale up, okay, then we deployed the personnel from another division, okay. Initially meant solely under disease control division, but then we rope in those from, say, family development division from the Ministry of Health, okay? And not only that, we also rope in the volunteers. So the volunteers, even the NGO activists, So they were very helpful, especially in managing the mental health. We started up our online numbers, a number of teams of counselors. So we got helped from the NGO volunteers. Okay, and to fast forward, what I knew about 2 months ago, when we are facing the third wave, which is now still with a very high number of cases, still about 3,000 cases per day. Ministry of Health actually they engaged more than 40 doctors under contract basis, about 2 months ago. So all in all, I think the CPRC at the moment simply they got more than 100 doctors and staff running every day on the daily basis, more than 100 people in the CPRC Putrajaya. So that's how we scale up the manpower, anticipating this COVID-19 surges.
Yeah. Thank you, Dr. Suman. There are two questions, I think. So please, what is the relationship between the Ministry of Health and CPRC? How do they interact? And,
right. Okay.
Yes.
Okay, for the first one, obviously the CPRC is belong to the Ministry of Health. It is under the Ministry of Health. As I just mentioned, actually CPRC is just one platform under the Disaster Outbreak Crisis and Emergency sector under the Disease Control Division, the Ministry of Health Malaysia. So it is rightly belong to the Ministry of Health Malaysia. Okay. And second question, the first line of CS is the police. All right, okay. Thank you very much for this question. Okay, for Malaysia, say for the disaster response, it is under the National Security Council Directive 20, for example, yeah. And there are any other directives, Directive 18 for the security events, Directive 20 for the public disorder, okay. Always the police is the commander at the scene, always, yeah. The military is the supportive agency, but usually the military as, I would say, the last resort. There are other agencies, for example, civil defense, fire and rescue department, that will come very closely to police in helping manning the scene. The military will be the last resort to help the police. Thank you.
Thank you. Thank you, Doctor, for your comments. Now, we will now move on to our first oral presenter for this afternoon. I would like to welcome Ms. Esther Sim Wanbong, student from School of Medicine, Faculty of Health and Medical Sciences, Taylor's University, to tell us about her team research on systemic review of the incidence of acute ischemic stroke in COVID-19 patients. Dr. Badrul and Associate Professor Dr. Fidel Fernandez will be our judge for this presentation. I would like to invite Ms. Esther to present her research. Welcome, Ms. Esther Sim.
Hi everyone, my name is Esther and I'm currently part of a research team. Our paper is entitled Systematic Review on the Incidence of Stroke in COVID-19 Patients, an Urgent Need for Early Management. Our team consists of 6 people, mostly third-year medical students such as myself, Dolly Chateau, Shannon K. Chan, and Alentino Raven Daniel. Our team is led by Dr. Jawid from Taylor's University School of Medicine and Dr. Ashmal from Jamaica Hospital Medical Center. COVID-19 has besieged the world with its high morbidity and mortality rates. And to date, the number of confirmed COVID cases has already surpassed the 100 million mark, with over 2 million deaths globally. While most of us are aware that SARS coronavirus 2 infection primarily causes respiratory disease, there is emerging literature reporting on the extensive effects of the infection on virtually all organs. This can be attributed to the fact that ACE2 receptor, also known as angiotensin-converting enzyme 2 receptor, is the entry point for this coronavirus. And this is expressed and found in many organs besides the lungs, such as the kidneys, the heart, the gastrointestinal tract, and the endothelial cells, which make up the lining of our blood vessels, both our arteries and our veins, including those found in the brain. Hence, direct viral damage to these tissues and subsequent inflammation actually cause these extrapulmonary manifestations of COVID. The main neurologic manifestation of COVID discussed in our paper is stroke, particularly and specifically acute ischemic stroke. This was one of the very first few studies published reporting on stroke as a presenting feature among COVID patients. This was published in April 2020 in the New England Journal of Medicine, and it garnered great attention worldwide by clinicians and physicians due to the unusual presentation of stroke in COVID and the fact that all 5 patients in this report were below 50 years of age, 2 of whom had no significant risk factors or underlying comorbidities that predisposed them to stroke. Subsequently, more and more studies emerged documenting stroke as a potential complication of COVID-19 disease, particularly COVID-19 associated coagulopathy. And in this case, the blood clotting mechanisms of these patients are impaired, and they are more likely to have a prothrombotic state, where there is an increased incidence in blood clot formation in the veins and the arteries. So acute ischemic stroke is a manifestation when the cerebral arteries are occluded. And this study concluded that COVID-19 disease itself is an independent risk factor for acute ischemic stroke. The researchers in this study matched cases with controls. Cases were patients with confirmed acute stroke on imaging, and controls were patients who underwent imaging but had no evidence of stroke. Cases and controls were matched by age, gender, and risk factors. And after performing the appropriate statistical analysis, the researchers concluded that COVID-19 was independently and significantly associated with acute ischemic stroke. Our paper aims to gather the current available literature and summarize our understanding on the association between COVID and acute ischemic stroke, as well as tabulate and collect relevant data and statistics, such as the incidence of stroke among COVID patients, the clinical characteristics of these patients, identify which vessels are commonly involved, the important lab findings, as well as the outcome. Our paper will also discuss early management of COVID-19 patients based on current evidence and guidelines by the WHO and also international societies. We conducted a systematic review in accordance with the PRISMA guidelines. Comprehensive literature search was performed in PubMed, Google Scholar, Cochrane Library, and Embase from 1st October 2020 to 1st January 2021. And all studies that reported acute ischemic stroke among COVID patients were included during our initial search. And this consisted of systematic reviews, retrospective observational studies, case series, and case reports. And the keywords that were used are as follows. Studies that reported only hemorrhagic stroke and cerebral venous thrombosis were excluded. Based on our PRISMA diagram on our right, our electronic search strategy yielded 573 studies during our initial search. Duplicates were removed, and after screening studies based on abstract and full text review, we excluded those that provided irrelevant and insufficient data. And this amounted to a final total of 22 studies that were included in our paper, consisting of 10 systematic reviews, 10 retrospective observational studies, and 2 case series. After extracting our data, we tabulated our findings into an Excel sheet. The total number of participants from all studies included in our review amounted to over 140,000 people, and all were infected with COVID-19. The incidence of stroke in general among COVID patients ranged from 0.9 to 5%, and out of which acute ischemic stroke was the most frequent type of stroke among COVID patients, comprising 78 to 96.6%. The mortality rate among stroke patients with COVID was high, ranging from 29.2 to 64%. And 2 systematic reviews compared this with the mortality rate of stroke patients without COVID, which was significantly lower. The most common presenting symptoms of stroke in COVID patients were the typical stroke symptoms, such as unilateral weakness, altered mental status, and dysarthria or speech disturbances. Although some studies documented strokes in young COVID patients, stroke was predominantly found in the older age group with a male predominance. Most patients had underlying comorbidities such as hypertension, diabetes, and hyperlipidemia. And in most cases, stroke was categorized as moderate to severe stroke based on the NIHSS score. And this is a tool used to objectively quantify the severity of stroke, 0 being the minimum score, and 42 is the highest possible score. So the higher the score, the greater the level of impairment. And in this case, 9.79 to 21.5 fall under the moderate to severe kind of stroke. We also found out that the onset and diagnosis of stroke occurred 7 to 16 days after the onset of COVID symptoms. So this is more of a delayed presentation. And we managed to find out that anterior circulation is the most common site for stroke, with quite a significant number of strokes occurring in the middle cerebral artery, whereas strokes involving the internal carotid artery and the posterior circulation were less common. Multiple vascular territories or multi-territorial strokes were seen in 26 to 30% of patients, and this could be due to the propensity of systemic embolization and microvascular thrombosis that occur in COVID patients. In terms of the etiology or cause of stroke, most papers that were included in the review mentioned TOAST classification, which was developed to categorize the subtypes of ischemic stroke based on its etiology or cause. Large vessel occlusion and cryptogenic subtypes of stroke were the most prevalent types among COVID patients, followed by cardioembolic and small vessel occlusion strokes. Large vessel occlusion strokes are secondary to large artery atherosclerosis, and this most commonly affects patients with the underlying risk factors such as hypertension, dyslipidemia, and diabetes, while cryptogenic strokes are strokes that are not clearly attributable to a definite cause. So it's not caused by atherosclerotic disease or small artery disease or cardioembolic phenomenon. And in this picture, it's showing an occlusion involving the middle cerebral artery, particularly the M1 segment. So here are a few imaging from the retrospective observational studies that were included in our review. So this shows chest and brain CT images of a 79-year-old COVID patient with stroke. Figures A, B, and C show chest CT images before treatment, 10 days after treatment, and before discharge, respectively. While figures D, E, F, and G show brain CT images on admission that demonstrates infarction of the bilateral corona radiata. And this area is actually supplied by the middle cerebral artery, the M1 segment, which contains the small penetrating arteries, also known as the ventricular striate arteries, which is the most common site of occlusion among stroke patients with COVID. And this is a patient with severe COVID who developed acute ischemic stroke due to large vessel occlusion. A and B shows severe pulmonary injury and inflammation in the lungs on CT angiography and chest X-ray, respectively. D shows occlusion of the M2 segment of the middle cerebral artery, and C is a CT perfusion map that is done to examine the cerebral blood flow or perfusion in the brain. And 4 important parameters are reported in this CT perfusion map, which are cerebral blood flow, cerebral blood volume, time to drain, and mean transit time. And these findings are consistent with ischemic stroke. As you can see, there is significantly decreased blood flow in the right hemisphere of the brain. And corresponding to that are delayed and increased mean transit time and time to drain. Lab findings in acute ischemic stroke were consistent with COVID-19 associated coagulopathy. Elevated D-dimer levels were the most common finding, and this is the hallmark of severe infection, and this reflects an inflammatory and procoagulant state of COVID. Elevated fibrinogen was also seen in most patients, and this indicates the persistent activation of the clotting and fibrinolytic cascades. Inflammatory markers such as CRP and LDH were also elevated in most patients, along with positive antiphospholipid antibodies. And this is hypothesized to contribute to the pathogenesis of stroke in COVID patients. So based on the data collected, anticoagulation and antiplatelet therapies such as clopidogrel and aspirin were mostly administered in COVID patients who develop a stroke. And this is to prevent occurrence of recurrent and subsequent strokes. Mechanical thrombectomy and intravenous thrombolysis were also performed. Mechanical thrombectomy is most commonly suited for large vessel occlusion, and this is a minimally invasive procedure that is done to remove the clot from an occluded vessel. And intravenous thrombolysis is usually done with recombinant tissue plasminogen activators such as alteplase to lyse the clot. So this is a guideline document intended for clinicians caring for COVID patients published by the WHO in May 2020. And this guideline states that COVID has been associated with prominent features of widespread inflammation and a prothrombotic coagulopathy, And this includes both venous and arterial events, such as deep venous thrombosis and stroke. Given the prothrombotic nature of coronavirus, all patients admitted with COVID-19 should receive thromboprophylaxis with low molecular weight heparin and should be monitored for all signs and symptoms suggestive of thromboembolism, such as stroke, DVT, pulmonary embolism, or acute coronary syndrome. And this chart is from a paper which gathered insights from an international panel on the management of acute ischemic stroke among COVID patients. So firstly, the COVID status of the patient should be obtained for early identification and separation, followed by a clinical evaluation and lab investigations to identify any organ dysfunction, and followed by a CT scan of the brain. And this can be supplemented by contrast-based studies such as CT angiography or CT perfusion scan. And subsequently, IV thrombolysis or mechanical thrombectomy can be done following CT scan. So in terms of prophylactic anticoagulation used in COVID, this paper was published in Singapore Medical Journal, and it's entitled A Review of COVID-19 Related Thrombosis and Anticoagulation Strategies Specific to the Asian Population. And although this paper is specific in terms of its target population, it referenced quite a few important studies, and it talked about how prophylactic anticoagulation use in COVID patients is associated with better outcomes. So these are the two important findings. The first study reported that the use of prophylactic doses of low molecular weight heparin was associated with a significant reduction in 28-day mortality for patients with severe COVID-19 disease. And another large cohort study evaluated the anticoagulation use in COVID in the US. And they reported that the use of treatment doses of anticoagulation was associated with a significant reduction in hospital mortality rates, which is 29.1% compared to 62.7% seen in those not on therapeutic dose. So that is if they are under prophylactic dose or no anticoagulation at all. However, more studies are needed to investigate the efficacy of therapeutic versus prophylactic doses of low molecular weight heparin, especially in severely ill patients. And randomized clinical trials are actually underway. So in conclusion, most reported cases of stroke in COVID are acute ischemic stroke with a male predominance, and the most common comorbidities are hypertension, diabetes, and hyperlipidemia. Stroke patients with COVID have a higher NIHSS score and mortality rate, and the most common lab finding is elevated D-dimer. And these lab parameters and these common clinical characteristics among COVID patients can help clinicians identify patients who are at risk of developing stroke in order to reduce morbidity and mortality rates. And these are references for this presentation. Thank you.
Thank you, Ms. Esther, for that very interesting presentation. We will now take some questions from Dr. Badrul and Dr. Fidel and the audience.
Right. May I ask
yes,
the questions? Okay. Thank you for the presentation. Very interesting. I would like to know on the ultimately that for the systematic review, the team conducted on systematic review on the 22 studies. May I know among the 22 studies, mainly from which countries or from which region in the world that included in this, the final, 22 studies that being systematically reviewed by the team? Any other country or any study from Malaysia or from this region, for example, among these 22 studies?
Okay, thank you, Dr. Badrul, for the question. So for Malaysia, there's very limited studies on stroke among COVID patients. So our systematic reviews and case reports and case series that we included in our studies mainly come from the US, Europe, and China. Yeah.
US, Europe, and China. Okay. The second last slide about the studies, the anticoagulation treatment that you mentioned, one from Singapore and one from the US. Are they both included in these 22 studies, or they are different references altogether? Just merely referring to the anticoagulation treatment.
In some of the systematic reviews that we included in this study, they are quite old, I mean relatively old. They were published last year in April or May. So they didn't include recent anticoagulation management that have been released recently. So this is something additional that we added to our systematic review.
All right, okay, thank you very much.
Thank you.
Over to Dr. Fidel. You're muted, please. Not able to hear. Dr. Fidel, you're not. Yes, now.
Okay. I'd like to get your justification or the reason why, apart from many organ involvement in COVID, why did you choose? What's the relevance of your study? Because COVID affects multi-organ, and in fact, the primary organ involved is the respiratory system. But this review is particularly very interested in the central nervous system pathology. Why? What's the reason?
Thank you, Mr. Fidel, for the question. So one of the significance of our study is because we found out that the mortality in terms of stroke patients with COVID and without COVID is very, very different, significantly higher, much higher in those with COVID disease. So this difference in mortality really is a problem. So we decided to tackle this topic, and hopefully with more I guess if we spread this news, more action can be taken, and early management can be taken to reduce mortality. Yeah.
Okay.
Yeah, these patients
one
are
more.
very
Yeah. Did you find out that these patients that were reviewed really died of central nervous system failure rather than the respiratory failure? Because if this is a disease that primarily involves the respiratory system, then I'd expect that most of them will die of respiratory failure. But did you have any data about the death directly due to stroke? Because most of ischemic stroke, if you happen to go to the clinical aspect of the ischemic stroke, in the first second, very hard to get a fatal disease in actual clinical practice of, in the clinical practice, we really hardly find a direct death due to ischemic stroke. Instead, we have a lot of deaths with hemorrhagic, but you're talking about ischemic stroke. Did you find data about the direct cause of death?
We didn't find data on the direct cause of death, but in several systematic reviews that was included in this study, they mentioned a bit of the outcomes. So the outcomes are quite poor in terms of COVID patients who develop stroke, and mostly unfavorable, mostly died, and some remain bedridden, and a significant number of patients also develop venous thromboembolism. So the morbidity is high, but more studies are needed to review this.
Thank you.
Okay, thank you, Esther. There are two questions on the screen, so will you answer that? The first question is from Dr. Akhil Daher. From the reports you have reviewed, which type of stroke is more prevalent, ischemic or hemorrhagic, and why?
So ischemic stroke is more prevalent. Basically, the mechanism is due to vasculitis. There are many mechanisms. So firstly, vasculitis. So the viral infection of the vascular endothelium causes endothelial cell dysfunction and also activation of the coagulation cascade. So this causes a more hypercoagulable state, so more thrombus formation, so more occlusion, and hence ischemic stroke. And another mechanism of ischemic stroke actually is due to cardiomyopathy. And in patients who are very ill, such as COVID patients, they might develop cardiomyopathy, that means cardiac dysfunction, so their heart could develop arrhythmias, and this can consequently cause thrombus formation and it can dislodge and occlude the vessels of the brain. So because of these various mechanisms, ischemic stroke is more prevalent.
Thank you. Next question. Why did you include the studies between October 2020 and January 2021? Any particular reason for the studies?
So we included studies in this timeline because most studies were available around October 2020. More comprehensive studies were available around this time, and the studies that we took from July were updated in terms of the management. And yeah, so basically we added more recent guidelines and recent studies around this period.
Okay, thank you, Esther. Now we will move on to our second oral presenter. I would like to welcome Ms. Olivia Bong, student from the School of Medicine, International Medical University, to tell us about their research topic, general population's worry and perception of stigma towards COVID-19 infection in Malaysia. As before, Dr. Badrul and Dr. Fidel will be judging this presentation. I'd like to invite Ms. Olivia to present their research. Welcome, Ms. Olivia Bong.
Good afternoon, everyone. My name is Olivia, and I'm a third-year medical student from the International Medical University. It is my pleasure to present our community health research project titled General Population's Worry and Perception of Stigma Towards the COVID-19 Infection in Malaysia. This project was carried out by a team of 19 students, including myself, on the 7th of January this year. Without further ado, let us take a look at some background information on COVID-19. Ever since its emergence in Wuhan City, China in December 2019, the disease rapidly became a major public health threat worldwide. And by the 25th of January 2020, the first positive case of COVID-19 in Malaysia was recorded. Undeniably, the pandemic has affected the community in many ways. Fear, anxiety, and loneliness has caused great psychological distress, especially in vulnerable groups such as those with pre-existing mental illnesses, long-term patients, and their caretakers. Next is the emergence of COVID-19 associated stigma. In the context of health, social stigma can be defined by the World Health Organization as shown, and in the current climate, those most affected by this discrimination include COVID-19 patients, their families, and frontline workers, just to name a few. As a consequence of social stigma, individuals may feel the need to hide their symptoms in fear of discrimination. Individuals may also be reluctant to seek proper care, which will undermine public health efforts to contain the spread of the virus. Our problem statement is as such. What we know is that COVID-19 associated stigma has had a negative impact on our community, be it psychologically or socially. To tackle this issue, however, it is important to further understand the extent of stigmatism in Malaysia and identify which factors are affecting this perception of stigma. This is so we are able to form specific strategies to combat stigmatism in the context of Malaysia's culture and people. The objectives of our study are as follows. First and foremost, to determine the level of stigmatization and worry towards COVID-19 infections among the general population here in Malaysia, and more specifically, to identify the level of stigmatization and worry towards COVID-19 patients and frontline workers. Next, to determine any factors associated with the level of stigmatization, be it socio-demographic variables such as gender, age, and ethnicity. Also, to determine the relationship between worry and COVID-19 stigmatization. Throughout the study, we ask ourselves, what is the level of stigma and worry towards COVID-19 patients and frontline workers? Is there a relationship between the level of stigmatization and socio-demographic variables? And is there a relationship between worry and COVID-19 stigmatization? From this, we hypothesize that the general population in Malaysia will have a low level of stigmatization towards COVID-19. Educational attainment and ethnicity will be associated with a lower level of stigmatization, and there will be a moderate to large correlation between worry and level of stigmatization. Now let us take a look at some past studies in regards to a concept known as the infodemic. The term infodemic describes the bombardment of both accurate and false information on COVID-19. For example, I'm sure many of you have WhatsApp groups with family members, and I've received many article links and even videos containing information on the pandemic. This becomes a problem when, and I quote from WHO, it drives anxiety and fear amongst the public. The fear of being infected, along with the social norm of isolating those infected, breeds stigma towards the COVID-19 infection and those associated with it as well. This is shown by verbal abuse hurled towards healthcare workers and cases of physical assault on Chinese people across the globe. However, the infodemic alone does not generate stigma. Namely, when coupled with knowledge gaps in the general population, misuse of social media in sharing misleading information, and political leaders shifting blame to further their political agenda. Past studies have also shown that certain social demographic variables can affect one's perception of stigma. For starters, females were found to have experienced less stigma when getting help for psychiatric disorders, but more stigma when approaching geriatric care. Ethnicity was also found to play a major role as well. For example, African Americans in the States were found to receive more stigma as compared to Caucasians in mental illness studies. In Mali, their culture has led to stigmatization of HIV patients, labeling them as being punished by God. Religion has also been found to affect stigma, as there were higher levels of stigma amongst Christian nurses when treating HIV patients. Last but not least, a higher education level has shown to decrease stigma endorsement due to more understanding and knowledge of factors that are prone to stigma. As for our study methodology, a cross-sectional study design was done, the general population of Malaysia was targeted, voluntary participation was ensured, and participants were recruited regardless of socio-demographic characteristics. Individuals below the age of 18 years old were excluded, as well as non-English speakers, as we did not translate our questionnaire, which was written in English. Sample size was calculated using the formula for comparing two means. To detect a difference of 2 in mean stigma score with an estimated 10% non-response rate, our final sample size was 422. However, due to the online nature of data collection, 451 questionnaires were distributed through snowball sampling, of which 6 did not respond, yielding a response rate of 98.7%. The online survey was also used in favor of physical forms due to social distancing regulations. When collecting data, we ensured voluntary participation and informed consent. Our online survey consisted of 3 parts. Part 1 collected the social demographic characteristics of our respondents, such as age, gender, and level of education. Part 2 assessed participants' level of stigma towards COVID-19. For example, do you agree that all foreign workers are at a high risk of transmitting COVID-19? There were 9 questions in this section to be answered on a 5-point Likert scale ranging from 1, strongly disagree, to 5, strongly agree, with a higher score correlating to a higher level of stigma. Part 3, on the other hand, assessed participants' level of worry towards COVID-19. For example, how concerned are you about your family members being affected by COVID-19? There were 7 questions in this section to be answered on a 5-point Likert scale as well, but ranging from 1, not concerned, to 5, very concerned, with a higher score correlating to a higher level of worry. The data was analyzed using SPSS version 24. Categorical variables were described with frequencies and percentages, while numerical variables were described with mean, median, and interquartile range when applicable. Measures of normality for both distribution of stigma score and worry score was done. Comparison of mean stigma score between 2 groups of social demographic data was done using the independent samples t-test, and if there was more than 2 groups, the ANOVA test was used. A non-parametric correlation test was also done between stigma score, worry score, and age. Now for the results of our study. Table 1 demonstrates the characteristics of respondents. We found that almost half of our participants were female, while the rest were male. Majority of participants were Chinese, while Buddhist participants accounted for 46.1%. Christians gave rise to 18.4%, while the rest were Muslim or Hindu. Majority of participants were either single and living with family, while only less than 5% were living alone or with friends. Lastly, the median age of participants was approximately 23 years old. Table 2 shows the participants' response to questions about stigma. Here, more than 64% of participants agreed that all foreign workers are at high risk of transmitting COVID-19. Majority also agreed to isolate those infected from society. In contrast, 80.4% disagreed that getting infected by COVID-19 is embarrassing, and around half of participants disagreed that they are afraid of those infected or recovered from COVID-19. Interestingly, participants had a more neutral opinion when asked about healthcare workers, as shown in green. Namely, if healthcare workers should be isolated or if they fear infection from healthcare workers. Here we have the participants' response to questions about the worries of COVID-19, where more than 60 to 70% of participants expressed their concerns in regards to major aspects of COVID-19. It is also seen that participants were especially concerned about their family members being affected by COVID-19, specifically 75.8%. We found a statistically significant difference in the mean stigma score when comparing participants' education level, whereby participants with a lower education level had a higher mean stigma score. Furthermore, the mean stigma score among respondents who have had close friends or relatives infected by COVID-19 is significantly lower than that of their counterparts. Gender and medical professional status do not significantly affect participants' mean stigma score. Participants' mean stigma score was around 26.55. This places the general population at a medium level of stigma between quartiles 3 and 4. To be precise, around half of participants had a stigma score more than 27, which was 50% of the total stigma score. It is also shown that the mean worry score is approximately 30, which places the general population at a very high worry level. It is also noteworthy that only 10.7% of participants had a none to low worry level. Using ANOVA with post-hoc tests, it was found that Chinese participants had a significantly higher mean stigma score compared to Indians and other ethnicities. Likewise, Buddhist participants had significantly higher mean stigma scores compared to other religions. Lastly, a non-parametric correlation between stigma score towards worry score showed a significant medium positive correlation, but there was no significant correlation between mean stigma score and age. Moving on to our discussion, the first topic discussed was why most of our participants were Chinese. This is because the sampling method we adopted in the research was snowball sampling, which is a non-random sampling. Since majority of group members are Chinese, hence approximately 70% of our participants were Chinese as well. Secondly, over half of participants agreed that foreign workers are at a higher risk of transmitting COVID-19. To help explain this, a JMIR publication stated that in this modern society, advanced technologies such as smartphones and tablets have become a necessity to daily life, and the internet as well can be easily accessed by everyone. Subsequently, those who lack awareness or knowledge about the virus can be easily manipulated by social media or news channels, which sensationalize foreign workers as the main source of COVID-19 outbreaks. Next, a large proportion of participants worry about the death of close friends or family from COVID-19. Since the median age of our study is 23 years old, we assume our participants are concerned about their parents or older relatives due to the elderly having a higher mortality rate compared to younger individuals, and this is according to a journal in BMC Public Health. Moving on, a large group of participants with close relatives who have already been infected by COVID-19 have a lower stigma score. This could be because the relatives or friends of those infected are able to express more compassion and empathy towards other COVID-19 patients. Furthermore, they would have a better understanding and awareness of COVID-19 and its transmission. Next, Chinese participants were found to have significantly higher mean stigma scores. This could be attributed to the Chinese Confucian philosophy, whereby any form of exposing personal weakness brings a negative impact to the society and family harmony. Furthermore, according to a journal published by Gan Xiaofei, Chinese culture believes that people should be responsible for the outcomes of personal choices. Likewise, those infected with COVID-19 should be psychologically ready to receive any stigmatization or discrimination. Finally, increasing cases of COVID-19 in the community has significantly increased the distress of the population. This leads to higher stigma scores. According to a journal by William J. L., people tend to worry about the health status of family members and friends. Because of that, people get more defensive in order to protect those close to them. This can be seen in defense policies, which focus more on protecting the masses against the spread of COVID-19 rather than protecting the basic human rights and interests of those infected. Some limitations of our study include its snowball sampling method, which was non-random sampling. Furthermore, our survey was only available in English, which limited the participants to those who understand the language. Also, individuals who live in rural areas with insufficient Wi-Fi coverage might have problems accessing the online survey. In conclusion, our study has shown that the general Malaysian population has a medium level of stigma and high levels of worry towards COVID-19. Chinese and Buddhist participants have a higher stigma score, along with participants with high levels of worry. In contrast, participants with a higher education level have shown to have lower stigma scores. With this and further studies, we hope to be one step closer to understanding COVID-19 stigmatism and how it can be decreased within the community. Thank you.
Thank you, Ms. Olivia Bong, for that very interesting presentation. We will now take some questions from the judges and the audience.
May I ask first, Dr. Saj?
Yes, please. Yes, Dr. Guru.
Right. Olivia, thank you very much for your presentation. First of all, I would like to know, because the median age of your participants is 23 years old, right?
Yes, doctor.
Okay, so basically, who are they and where are they coming from? Where are they live throughout Malaysia? Can I know?
Yes. So we have a couple of participants all around Malaysia, but majority would be following where our group members are staying. So majority from KL and also Selangor.
All right. Okay. I think, well, I think it is not truly representative of general population of Malaysia. So that maybe the title is because you say in Malaysia as a whole, so it may not that representative in my opinion. Another thing, yes, you have highlighted the limitation of only the English spoken persons, as well
Yes.
as only those that accessible to the IT device, right? To answer for the question.
Yes.
All right. Okay then. Thank you very much.
Yes, thank you, Dr. Badru. We do acknowledge that that is a limitation. So far from our results in terms of demographic data, we've obtained participants from 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 states already in Malaysia. But yes, we do acknowledge that as a limitation. Thank you.
Okay. Thank you.
Thank you. Dr. Fidel, can
Yes.
ask you this? Yes, please.
Yes, I'd like, since you have concluded that the stigma and worry rely on education, meaning what the public knows about COVID. Can you tell us about how the impact of the mainstream media in comparison to the social media would give to the general public, since this is the area which you have chosen? Do you think that the mainstream media would give more impact on the education, information about COVID than the social media, or is it the social media over the mainstream media? What's your opinion?
Yes, Dr. Phil. So just to double check, your question is which one has more impact in terms of people's perception of stigma, whether or not mainstream media such as maybe TV channels and all and social media?
Yes, exactly.
Okay, thank you. In my opinion, it's definitely social media for the younger generation. But even now, if we look at our grandparents and our parents, everyone has a smartphone if we're talking about the urban population. And most likely, when I talked about the infodemic and how information disseminates, I feel like it's much more faster for it to transmit through social media such as WhatsApp and also Instagram, because these are very popular avenues for information. But if we talk about mainstream news sources such as television, news channels, and all, for the younger population, which is now majority of, let's say, the population in Malaysia, it may not be that popular amongst that generation because they will not find the time to go on and look at the kind of information that is being broadcasted on TV channels.
Okay, so is it okay? Is it directly related to the amount of stigma and worry, the information taken from social media? Do you think that the perception of people through the social media gives a very, gives a very, a strong impact on the response of the people in terms of the perception of what is true and what is false? Because social media is a mixture, it's a salad of true and false information. So
Yes.
does it give a bigger impact than what we officially give through like scientific journals and written reports and the mass media and so on? How that affect? Do you believe that social media really has a negative impact in the bottom line is, does the social media have a bigger negative impact on the perception of COVID?
Thank you for your question, Dr. Fiddle. Yes, I do believe that there is a negative impact, especially with social media, for the reason that as people who are in sciences, we understand that the only trustworthy information will come from our journal articles where we can really validate the source and the scientific procedures for this information that's being disseminated. But for the layman and the people around us, maybe our family and all, it's very easy to just receive a link from an article from a very untrustworthy source with a headline saying, oh, latest news on COVID-19. And if they do not have the knowledge that we do on trustworthy sources of information, journal articles, and how to interpret them, then it is quite easy to get misled by these kinds of information. So our responsibility in that respect for me is to really catch the disseminating of these kinds of articles and put a stop to its dissemination with just a simple, this is not a trustworthy source. Instead, please focus on articles published by so-and-so sort of website. Yes, so it really depends on the knowledge of the general population, in my opinion, and if they know what is trustworthy or not in social media.
Yeah, very good. And yeah, I'd like to also commend the organizers because they are tackling this issue right here and on ground zero. Yeah, thank you.
Yes.
Thank you, Ms. Olivia. As there is no other questions from the audience, we will now move. Yes.
Sorry for interruption. Before we go to the next speaker, a short break, and I'd like to invite Dr. Sapna and Dr. Joanne, our organizer of the conference, to announce the raffle prize. Just for a few minutes.
Thank you. Yes, over to Dr. Sapna.
Dr. Sapna and Dr. Joanne. Sorry, Joanne.
Thank you, Dr. Imam and Prof. Shahjan. Hello, everyone.
Hello.
Hey, Dr. Joanne, where are you?
Hello.
Good afternoon, everyone. We're back. Yeah, we are back. Okay.
Thank you.
So we are looking again for a volunteer to select a lucky winner for our next raffle prize. So Dr. Joanne, do you want to select or you want to just ask someone who wants to be a volunteer?
Yeah, anyone who would want to be a volunteer? Or we can pick someone from the list. Reef Bacchus is a familiar name. I think he joined the logo competition. Reef Bacchus, are you here? Did I pronounce your name right? Arif? Or maybe we can call another one, Dr. Sapna.
Okay.
Maybe you can just give me another name, Dr. Sapna, so just another name from the list.
Sure. Can we have Ratnadeep Saha? Are you here?
Ratnadeep Saha, are you here?
Yes, I'm here.
Wow, please turn on your video. Whoa, there you go. Hi, good afternoon.
Good afternoon.
Are you from Malaysia?
Yes, I'm from Malaysia. I'm actually an Indian citizen, but working in New Med, Malaysia.
Hello, Dr. Ratnadeep. Good to see you. Old colleagues connecting. Good
Yeah,
to see
thank you,
in the
Dr. Sapna.
conference. Hope you're well. How are you?
Yes, I'm fine.
Right. So we have selected you. I mean, we consider you as volunteer, first volunteer to select.
Okay.
Select for us one of the lucky prize winners. So, Dr. Joanne, could you please instruct Dr. Ratnadeep?
Yes, please instruct what to do.
I did not get from what university, doctor?
So this is from Newcastle University.
Oh, Newcastle University. All right. We have our colleagues there, Dr. Vivian, Dr. Sarah. Yeah. Thank you. Thank you. Doctor, can you just give a random number from 1 to 813?
So I have to choose any number 1
Yes.
to 813.
Yes, correct. Any number.
Okay. 797.
797. All right. Wait. Can you allow me to share screen, please? Thank you. Dr. Anita, can you allow me to share
Dr.
screen?
Imam, can you please allow screen sharing? Thank you.
The number is
797.
797. All right. 797. Let's see, 797. There you go. All right. This is Chan Shi Heng from Malaysia, Taylor's University. Is Chan Shi Heng here? Chan Shi Heng. One.
I think not here. Not here.
Not here,
here.
Dr. Joanne.
All right, then congratulations, Dr. Ratnadeep Saha. All right, so can we just take a screenshot? Just smile, say MEGOPIC. MEGOPIC. Thank you.
Thank you.
Bye.
Thank you, everyone.
See you later.
Enjoy your time.
Bye-bye.
Bye-bye. See you
Thank
later.
you, Sapna. Thank you, Dr. Joanne.
Thank you, Dr. Imam. Bye.
Okay, Dr. Sarjan, sorry for interruption,
Yes,
but
over.
continue.
Dr.
Thank you,
Imam.
Dr. Saha.
Thank you, Dr. Imam.
Okay.
Sarjan, can continue.
Our oral presenter, I would like to welcome. Yes, continuing. We will now move on to our third oral presenter. I would like to welcome Mr. Earl Cedric, a student from the College of Nursing, San Beda University, Philippines, to tell us about knowledge, attitude, and practice towards COVID-19 among student nurses. I'd like to invite Ms. Earl Cedric to present their research. Welcome, Mr. Earl.
Good day, everyone. We are from San Beda University, Philippines, and we are here to present our study entitled Knowledge, Attitude, and Practice Towards COVID-19 Among Student Nurses in Metro Manila, Philippines, a cross-sectional study. And to start, here is Ms. Raven Rose Tayaba.
So hello everyone, I am Raven Tayaba and I will be presenting the first few parts of our study. First is the introduction. So according to the professionals, the main factor on why COVID-19 continued to spread is due to people refuse to compromise. So for instance, on October 25, media released an article about 100,000 violators that was arrested by the PNP. Perhaps the violators doesn't take the precautionary measures seriously, or it was lack of knowledge or pessimistic attitude that leads to unsafe practice. So the main reason why we chose student nurses as our participants is because as early as their second year in nursing program, student nurses are taught how to educate people or to give health teaching in the community, assessing their current awareness and knowledge about the virus and its prevention can identify the gaps or the issues that can affect their perceptions and responses, which they can integrate in those people in the community. Therefore, this study aims to investigate the KAP, or the knowledge, attitude, and practice towards COVID-19 of the student nurses in Metro Manila during this pandemic. So for the objectives, this study aims to determine the demographic profile of student nurses, which can probably affect the KAP of the students. To assess the level of knowledge, attitude, and practice of student nurses about COVID-19. And lastly, to evaluate the association of the demographic profiles with the level of knowledge, attitude, and practice about COVID-19. So for our theoretical framework, we chose Sister Calista Roy's theory, which is adaptation model of nursing, to serve as the guide of our study because of the similarity of what the author would like to imply, which states that awareness of self and environment is rooted in thinking and feeling. So for our conceptual framework, this study will explore two sets of variables, which are independent variables and dependent variables. So for our independent variables, we have social demographic profile that includes age, sex, year level, family income, and religion. And for our dependent variables, we have knowledge, either good or poor, attitude, either positive or negative, and practice, either good or poor. So these sets of variables means that the only way to attain the final outcome of the government's aim is dependent to the compliance to precautionary measures of each individual, which is influenced by their KAP. The arrows between the independent variable and dependent variables states a possible impact that exists among the variables. For the methodology, for research design, we use descriptive cross-sectional survey for our study. And for sampling technique, we use purposive sampling technique. For the population, a total of 314 individuals participated in this study. The participants were nursing students, 18 years old and above, studying in a college or a university, either public or private inside Metro Manila, currently enrolled in academic year 2020 to 2021, and of course, had access to internet connection and understands the English language perfectly. So for the setting of the study, having the Philippines known as the social media capital, we use this advantage to spread and reach our target participants through emails, Facebook messengers, and other social media. So for the research instrument, we have 4 sets of questionnaires. First part is respondents' information. Second part is questionnaire on COVID-19 knowledge. Third part is attitude statement regarding COVID-19. And last part is the practices related to COVID-19. So for our method of data analysis, we use frequency, percentage, mean, standard deviation, independent t-test, and one-way ANOVA to analyze the data gathered from the selected participants. So for ethical consideration, the study was approved by San Beda University Research Ethics Board with protocol number 2020-040. So for the results, let's have Mr. Cedric Casal.
So thank you, Raven. Once again, everyone, good day. So now I will be discussing the results of our study. So earlier, it was determined that there were a total of 314 individuals who participated in this study, and different tables were used to present the data collected from these individuals. Table 1 shows the characteristics of the participants, which displays the mean knowledge score of 18.76 out of 22, indicating a high-level knowledge, while the mean attitude score was 26.58 out of 30, indicating positive attitudes. So the table also shows the mean score for practices that has a result of 4.26 out of 5, indicating good practice. On the total participants, it shows that majority of the respondents were females, having 234 individuals or 74.5% of them. Also, it appears that the majority of the participants came from level 1 as they are 122 individuals or 38.9% of the respondents. In terms of a type of school, students enrolled in private schools dominated those in public as they were 177 individuals or 56.4% of the participants. They were also grouped according to their family's monthly income, and it seems that majority came from those earning less than 20,000 per month. So the context of the next tables, tables 2 to 4, shows the participants' responses about KAP towards COVID-19. As I stated earlier, this study shows that the participants were very much knowledgeable about COVID-19, its precautions, symptoms, and the transmission of the virus. It also, however, manifests that more than half of the participants were still convinced that having close contact or eating wild animals causes COVID-19. This can be seen in the 4th item in table number 2. A total of 169 or 53.8% of the participants erroneously answered on this item. This exhibits that these participants still adhere to the claims that the virus came from bats that were ingested by the people in the marketplace in Wuhan, despite the fact that there are several reports claiming that there may be animals who tested positive for the virus, but there is still no evidence to suggest that animals are capable to transmit the virus to humans. Another significant error was 178 or 56.7% of the respondents believe that children are at higher risk for COVID-19 compared to adults. This is reflected in item number 13. This may be due to thinking that children have weaker immune system, but experts believe that children are not at higher risk, but is equally susceptible to the virus as adults do. For table number 3, this shows the responses of the participants regarding their attitude towards COVID-19, and it clearly shows that majority of the participants were very much optimistic in controlling this crisis. Table number 4 shows that the high level in knowledge and positive attitude reflect to their practice as they achieved a high mean score of 4.26 out of 5. Now here in table number 5, this is where we associated the participants' demographic characteristics to their mean scores. The data shows that among these differences, the year level and the type of institution appears to have significance. The proponents of this study found out that level 3 students has a higher mean score than other levels. This is different from the other studies that shows a higher level of knowledge in level 4 and level 5. This reflects the effectivity of the new curriculum where the nursing subject for communicable diseases is now embedded in the level 3, giving them more opportunities to have further information about such diseases at an earlier time. It also came to light that students from public schools has a higher mean scores than students from private schools, which is incongruent with other studies. This may be rooted from private schools' inferiority in terms of numbers, including quantity and quality of students and teachers, as well as support from authorities. Just like in the assessment of knowledge, the same differences were incorporated in attitude, and the difference in gender and type of institution were of significance. The results showed that women have the tendency to be more optimistic and have a positive attitude towards the crisis, which is also reflected in several studies. One study has also stressed that women are more proactive and interested in health related issues in general compared to men, resulting in this positive attitude. In addition, those students who are enrolled in private schools seem to be more positive than those in public schools. This may be due to students in private schools being more disciplined. So this discipline in following the ordinance set by the authorities contribute to their behavior and have a positive outlook in this current situation. For practice, it was only the year level that had significance, where level 3 seems to have a better practice than other year levels. This is a reflection of them being more knowledgeable and have a more positive outlook. The outcome of our study stipulates that majority of our participants have the fundamental knowledge on COVID-19, yet their performance may differ depending on their school type. Attitude in connection with COVID-19 manifests a gender discrepancy. Collectively, these outcomes show that sexuality and school methods may influence students' responses to COVID-19's upsurge and procurement of public health education. The said factors should be reckoned to construct contingency propositions or educations for the benefit of the students that might be used in the interchangeable public health catastrophes in the future. So for the conclusion, the current study was able to lay out an extensive exploration concerning the knowledge, attitude, and practice towards COVID-19 of student nurses in the Philippines. Knowledge about COVID-19 is pondered to be the first step in overcoming the infectious disease. In addition, we educated about its basic information such as its transmission and causes increases the possibility of people being mindful of the spread of the communicable disease. The outcome proves that Filipino student nurses have a justifiable level of knowledge in the said disease and are mainly optimistic in their perspective in controlling the pandemic. Nevertheless, having constant reminder from the authorities and healthcare professionals are the solution to aid public knowledge and comprehension related to COVID-19. So for the limitations and recommendations, as part of the strict measures implemented by the government to combat this COVID-19 pandemic, face-to-face classes were suspended, making the education department shift to online classes. This limited the authors to conduct the survey in a larger scale and narrow the scope to nursing students only. Also, due to the constraint, the authors were only able to reach students in two different schools in Metro Manila and only those who have reliable internet connection. It is recommended that further research should involve more participants from different regions throughout the country. Moreover, it is also advised to use more extensive methods of data analysis to further correlate the relationships of the different variables in order to fully understand the effects and impacts between these variables. So this ends our presentation. Thank you for listening.
We cannot hear you, Dr. Sarjan. I think you have to...
Yes, thank you. So thank you, Mr. Il, for the interesting presentation. We will now take some questions from the judges and the audience.
I think I'll let Dr. Fida Fernandez first.
Yes,
Yeah,
yes.
okay. Thank you, Dr. Badrul. Okay, my question would be, since this is knowledge and attitude and, knowledge and the reaction of people towards knowledge is connected. So my question would be, at what point in the pandemic is the basis for your knowledge? Meaning, the knowledge about COVID has changed from the beginning since we started the pandemic sometime December. And it has changed. The knowledge is slowly and every day evolving. And a lot of knowledge has been changed. Like, for example, from the time that it started, it was so fatal. A lot of, but times have changed. So I would want to know at which part of the pandemic was the knowledge taken? I mean, what was the basis of the knowledge, comparing the knowledge of all your participants? At what point in time in the pandemic were the knowledge based upon?
Thank you for that question po. So the data were collected during December in 2020 po. So there were no further studies prior to that.
Okay, so did it in your perception at present, if you did the same study on this the same participants, would they have different reactions, perceptions, attitudes, and practices? Would it differ?
Yeah, we believe so po. We believe that there will be changes.
Some change. And would you tell me, like, in what area would the change be expected?
So there are more after that period. There are more studies about COVID-19, and also the continuous reminders from the government persists. So I think about the knowledge, the transmission is what would be that will be changed. There will be an increase in the knowledge.
About the transmission, you mean?
Transmission and everything, even the prevention.
Okay. Okay. Thank you.
Thank you. Yes, Dr. Badru.
All right. Okay. Thank you very much for the presentation. My apology, because obviously I'm not very familiar with the nursing syllabus in the Philippines. May I know, when you say about the public and private schools, meaning that the nursing schools in the Philippines, some belong to the public sector and others in the private schools? Is that so? What do you mean?
Yes. Yes.
All right. Okay. And how many levels altogether until they are graduating? 4 levels or 5 levels altogether?
4.
4 levels.
Yes.
So I think one study you quoted that you are comparing with another study at level 4 and level 5. So that is not the study done in the Philippines, no?
Yes. Yes. That was another study from a different country.
All right. Okay. And from your findings, so it seems that the level 3 shows very good findings, right?
Yes.
Because they have the communicable disease syllabus during their level 3 that just being introduced, correct?
Yes. Yes.
All right. So it shows a significant difference in terms of much better in terms of knowledge as well as practice, correct?
Mm-hmm.
Right. Okay. I would like to know your opinion. So would you think that, is it still manageable, never too late, to briefly introduce this new syllabus of communicable disease to the level 4, that the level 4 that has missed this new syllabus, I suppose, but level 4 is the one that will be graduating soon. So what do you think? Will you think that it is still able to introduce maybe briefly on this communicable disease syllabus to level 4 just before they graduate, you think? What's your opinion?
Okay. Actually, sir, in the previous syllabus, the communicable diseases were embedded in the level 4. So this new syllabus is the current communicable diseases is now in level 3. And our level 4 now is included in the old curriculum.
So are you saying that the new curriculum for communicable diseases that just introduced is much better as compared to the old curriculum? Yes, you think so? Is that the main factor? What I mean is that the main factor that really contribute to the good performance among the level 3 because of the new curriculum of this communicable disease syllabus introduced to level 3?
So I think yes, because there are a lot more in the content is more in the level 3 compared to the level 4. So I think this during the level 4 there were only a part and parcel about the communicable diseases that was being discussed compared to the level 3 where it is more extensive.
More extensive. So it is applied to both private and public nursing schools, this new curriculum? Yes?
Yes. Yes.
All right. Okay. Thank you very much for the clarification. Thanks a lot.
Thank you, sir.
Thank you. I don't think so there's any question from the audience. So a big thank you to all the presenters for the session on COVID-19. It was a very interesting information from different angles, how to manage and how it is being, the pandemic is being managed from the beginning till now. I will now invite my co-chair, Dr. Umesh Bindal, to start off the next workshop session on mental health topic. Over to you, Dr. Umesh.
Okay. Thank you, Prof. Shajan, and good afternoon, everyone. Without further delay, we will now move on to a new theme on mental health. Okay, so our main speaker for this session will be Dr. Nadia Binti, and who will be giving us some insight in her view on mental health. So Dr. Nadia is currently working as a psychiatrist and a medical lecturer at National Defense University, Malaysia. She is a head of unit of psychiatry at Medical and Defense Health Faculty. Currently, she is practicing at the Specialist Center Hospital Angagatan Tentera Tuanku Mizan. She has a degree of Bachelor of Medicine and Bachelor of Surgery from International Islamic University, a Master of Medicine from University Technology Mara. Her special interest includes consultation, liaison, psychiatry, and women mental health. Well, she serves the Ministry of Health for 11 years before joining the university as a lecturer in 2018. She has experience as a trainer for cognitive behavioral therapy group, cognitive behavioral therapy, psychodynamic psychotherapy, and psychological first aid in Malaysia. Other than teaching, she is actively promoting mental health awareness and organizing events such as World Mental Health Day celebration, forums, workshops for staff and students, and NGOs. Currently, she is actively collaborating with her colleagues, conducting research with regard to mental health issues. I would like to invite Dr. Nadia to share her thoughts. Welcome, Dr. Nadia.
Assalamualaikum and hi everyone. Today I will be talking about COVID-19 and mental health. I am Dr. Rosnadia Soaimbun. I'm a psychiatrist and lecturer from National Defence University of Malaysia. Okay, so as we all know, COVID-19 began in the city of Wuhan. Before this, not many people are aware about the existence of this city. And suddenly, we heard about a cluster of pneumonia cases over there. A new virus was found and WHO was alerted. The infection spread very fast to all over the world, and in March 2019, it was declared as pandemic. Okay, China imposed lockdown in January 2020. In Malaysia, we have our own kind of lockdown, Movement Control Order or MCO in March 2020. Following the lockdown, public transport was shut down, school was closed, traveling, social gathering were prohibited, people even can't go to the gym to exercise, businesses closed down, and a lot of people unemployed. Now, 1 year has passed, but here we are still struggling with this pandemic. To date, it is very saddening that there are more than 100 million of cases all over the world, more than 2 million of deaths, and more than 80 million already recovered. Okay, social distance, work from home, online learning, apps such as Zoom, Google Meet become the new norm. Okay, coronavirus is a novel virus. There is a lot of things that we do not know yet about the virus. Infectious disease specialists in public health and scientists around the world are constantly putting their best effort to analyze the transmissibility, severity, natural history, and treatment of this virus. Human is a social being. We thrive from interacting with other human beings. With social distancing, isolation, and quarantine may produce psychological effects on the people. This is a study using systematic review and meta-analysis on prevalence of stress, anxiety, and depression among the general population. Okay, from the study here, we can see that 29.6% are stressed, 31.9% are having anxiety, and 33.7% are having depression. Okay, the question is, what about the students of higher learning? Okay, so for college and university students, the learning shift to online learning. So can they cope? They are the millennials. They are very tech savvy. However, it is easier said than done. A lot of challenges need to be overcome, be it for the students and also the educators. Okay, the students are facing a lot of challenges despite they are expected to be able to self-study and independent. Okay, if we see here from the technology itself, the issue of the availability of the laptop, of the tablet. Now that they are at home, they may need to share the gadgets with their siblings. And then comes the issue of the connectivity. If they are staying in a remote area, the internet connection may be poor. And then they will have a lot of technical issues during the online classes. And then the environment itself. Is it conducive? Is it comfortable to do the online learning? They may face a lot of distraction to study, right? And then from the student factors, right? The issue of the digital literacy. They need to have a certain degree of technology proficiency, including the ability to successfully log in, to participate in the classes, to submit their work, and even communicate with the teachers and the classmates, right? And a lot of them also having a problem to adapt, struggle to adapt to the new norm of learning, right? And then comes the issue of motivation. Now that they are not in the learning environment, the motivation may be poor, right? And then the issue of the time management. They have to juggle between the home commitment and also the online classes, right? And then from the teaching and learning, a lot of major exams postponed during this pandemic. So, due to the ongoing stressors and challenges faced by the students during the pandemic, they may have mental health issues, right? if these mental health issues are not handled properly, it may lead to mental disorders. Okay, here I want to show you a preliminary result of a local study. It is a cross-sectional study conducted during the second wave of COVID-19 in Malaysia from the 2nd of May to 15th of May 2020. The respondents were the NDUM students involving 603 students, including cadets and civilian. From the study, it was found that 36.1% students are having depressed, 38.3% students having anxiety, and 11.4% are stressed. So indeed, mental health issues among the students need to be addressed properly. So how do we enhance psychological well-being of the students? So we can see here, daily routine. It is important to set up a daily routine in order to get organized. It is easy to lose track when you are not in college attending physical classes, right? And then try to instill self-discipline in order to follow your daily routine. Okay, next. Staying at home with family, not in a learning atmosphere or surrounded by friends, you may lose your drive. Try to find the reason why you want to study and try to keep on track. Okay, and then the environment. Sometimes the environment may not be ideal to study. Okay, try your best and express your need to your family so that they can support you in providing a stable area for online learning. Okay, it is important to stay connected during pandemic. You may not be able to meet your friends, but try to keep in touch with friends. Ask about their well-being and also support each other. And it is easy to be done nowadays with the WhatsApps, video call, and many more. It is important to be organized. Keep a planner or reminder. Jot down important deadlines for assignments and exams. Okay, since you are away from friends, not in a study environment anymore, you have to keep on track. Okay, when you are stressed and tired with your routine, take a break from it. Okay, you may practice deep breathing exercise or mindfulness. Okay, so now let us do deep breathing exercise together. Okay, first you can sit or lie down in a comfortable position. Okay, put one hand on your stomach, another hand on your chest. Okay, you inhale through your nose and fill your belly on the count of 1, 2, 3, 4. You hold for 7, 6, 5, 4, 3, 2, 1. Exhale slowly. 8, 7, 6, 5, 4, 3, 2, 1. Okay, you can repeat this for a few more times until you are relaxed. Okay, so how to practice mindfulness? You can try to follow the mnemonic STOP. Okay, so now you can see here S. So S is stop whatever you are doing. T, you take a few deep breaths. O, you observe your feelings and needs. P, you plan and proceed with your activity. It is very easy to practice. Okay, don't forget to exercise. It is very important to maintain your general health and reduce your stress. So you can exercise at least 3 times per week, 20 to 30 minutes per session. And then next, try to have a healthy, balanced diet and have meal with your family. Eating together with family not only good for bonding, but allow you to share your worries and also fear with them. Okay, lastly, don't forget about spiritual well-being. Okay, even though place of worship are closed, you can do your prayer at home and perform your religious duties. It is very important to improve your mental health. It can reduce your stress, alleviate your anxiety and worries. Okay, I think that's all for my part. My last words, no health without mental health. Thank you very much.
Thank you, Dr. Nadia, for a very informative talk. Dr. Nadia will take on a few questions from the audiences now. Dr. Nadia, the first question, we are looking at the screen. What efforts are being made in your school to help with students' motivation?
Okay, thank you, Doctor, for the questions. Okay, so in National Defence University of Malaysia, a lot of efforts has been done for the students. All right, so we actually the Psychiatry Department and also the counselling unit in National Defence University of Malaysia, frequently we organise talks and forum for the students in order to help them to improve their mental health, right? And then not only that, we actually do provide an online link for the students to contact us if, let's say, they are having some mental health issues. Right, and then about the motivation also for the students, we actually each of the students, they are assigned with the mentor. So the mentor always keep on track with the students to contact them and make sure they are keeping in track with their studies. I think that's all that we try to help the students.
Okay, thank you, Dr. Nadia. There's another question on the screen. How will the forum improve mental health?
Okay, so thank you. Okay, because right now in pandemic area, we see that a lot of seminars, right, workshop, and even now our conference is done through online, right? So in this condition, we can't really attend classes or seminars, right, face to face. So in this condition, I think attending a lot of forums, it is good to improve the knowledge of the participants, especially, and for example, maybe they have they will learn about how to tackle the mental health issues, what to do when they are stressed, and then if they're having severe mental health condition, where can they get some help for it.
Thank you, Dr. Nadia. We have no more questions from the audiences. And thanks for the valuable tips, especially for the breathing exercises that if you're feeling tensed up, you just go in and take few breaths, and that's really helpful, definitely, sure.
Dr. Umesh, there is one more question.
There is another question, actually. In your opinion, do you think students trust their lecturers enough for it's hidden, actually, the last part. To seek help. To seek help, okay.
Okay, so I think for me, I'm a psychiatrist and I'm a lecturer also. So for me, as a psychiatrist, there's no problem for the patients to come and approach us, because we actually works according to our doctor's patients guide, right? We have to protect the confidentiality of the patients. I think in terms of the students, so that's why it is I think better for the students to be assigned into their mentor, right? When we assign them to a specific mentor, so the mentor will always follow up the students maybe from first year until they are in final year, so they are used to the lecturer already, right? So from time to time, the lecturer also have to show their concern about the students, right, about their problems, and then I think there should be no issue for the students to come and see the lecturer. Anyway, this is the point of view from me as a lecturer, right? I can't really talk on the behalf of the students, but I think for my students, I think they will come forward if they have any problems.
Surely, definitely. Thank you so much, Dr. Nadia. If our students also want.
A short announcement, Dr. Umesh, can I do?
Yeah.
Okay.
Sure.
Also to inform all, we are already live on YouTube. You can access the live and recorded video. Just type ICON-MEGOPIC 2021 and channel 3. So channel 3, this is channel 3, so you can find the video live. You can tell your family and friends and colleagues, they can see live around the world. Also, one short technical issue. So can I request Dr. Umesh and others to close the video once the presentation starts and then reopen the video once the presentation ends?
Sure.
Is that okay? Because if I have seen on the YouTube or the recorded video, the picture of the speaker also coming, sometime in one corner if the presenter is also in the same corner. So once I start the video, just to check some technical issues. Sorry for disturbing. So, okay, Dr. Umesh, continue.
Okay, I would like to thank Dr. Nadia once again for the valuable comments and a very nice presentation. Thank you, Dr. Nadia. So we will now move on to our fourth oral presenter of this afternoon. I would like to welcome Mr. Abhijit from International Medical University to tell us about the study on prevalence and determinants of depression among preclinical medical students in IMU. Dr. Nadia and Dr. Farzana will be the judges for the session. So I would like to ask or invite Mr. Abhijit to present his research. Welcome, Mr. Abhijit.
Our study is on the prevalence and determinants of depression among preclinical medical students at IMU. My name is Abhijit. This is our, next slide please. This is the abstract for our study. It gives an overview of each component, which we will be going into more detail about. Next slide please. So first I'll begin with an introduction to our study. Depression is a major public health concern. 284 million people of all ages worldwide are affected by this mental disorder, so it contributes significantly to the global burden of disease. The National Health and Morbidity Survey describes Malaysia as having one of the highest reported incidences of mental health illnesses, and this has been steadily increasing since 2011. As a state, KL is one of the highest prevalences of depression at 39.8%. Next slide, please. So generally, university students are more prone to depression, and this is because of a number of reasons. First of all, there is an abrupt environmental change from school to university. This brings with it an increased workload and level of stress that some students are not prepared for. Also, medical school is known for its sheer volume of content that's required to learn. And there's also a rigorous selection process that students need to undertake, which can also cause a great deal of stress. So there are some risk factors that can affect student mental health. And if these are left untreated, they can progress to the development of mental disorders. Some of these risk factors include academic pressure, insufficient financial support, or relationship problems. Furthermore, socio-demographic factors such as age, gender, and ethnicity also play a role in the development of depression. Next slide, please. So now I'd like to talk briefly about the justification for our study. So one of the main principles of medicine is that prevention is better than cure. And the best way to develop a suitable prevention method or management plan for depression would be to first understand the prevalence and factors associated with depression among a population of medical students. Next slide, please. Prior to commencing our study, we had a few research questions. These were, what is the prevalence of depression and the determinants of depression among preclinical medical students? Next slide, please. So our research objectives were split into general and specific objectives. Our general objective was to identify the prevalence and determinants of depression among preclinical medical students at private medical universities in Malaysia. And specifically, we looked at preclinical medical students at IMU. Next slide, please. Based on our specific objectives, we came up with a null hypothesis that there would be no association between depression and sociodemographic variables. And our alternate hypothesis was that there was in fact an association between depression and sociodemographic variables. I'd now like to pass on to my colleague who will speak about the literature review we conducted.
Hi, my name is Harishwa, and I'll be continuing the presentation from here. So I'll be talking about the literature review. Mental well-being tends to be neglected compared to physical health, and if this persists, it can progress to major health disorders. Some of the common symptoms of depression include a constant feeling of sadness and a loss of interest in activities that were once enjoyable. These negative thoughts and feelings can aggravate an individual to morbid actions such as suicide attempts. The morbidity, we'll look more at the effects of depression and how it's quite persistent. For example, sleep disturbances, anxiety, fatigue, and sexual dysfunction. Cognitive impairment is seen as well, and is not improved by antidepressants, as antidepressants merely elevate the mood. Next, we'll look at the mortality rate. Mortality risk is higher among depressed people, as the continuous suicidal thoughts may cause one to end their life. As for the prevalence, depression is more, the prevalence of depression varies from country to country. And based on a study in Pakistan, medical students from private universities experience more stress and depression. The determinants for depression, research exhibits positive correlation between prevalence of depression and demographic variables, such as age, gender, ethnicity, and so on. Next, we'll look at the study methodology. So we used a cross-sectional study that took a span of 3 days, and it involved semester 2 students and semester 5 students. As for the sample size, we calculated it using a sample size calculator. The software is BrowSoft, and we used the margin error of 5%, confidence level of 95%, response distribution of 28%, and we had a sample size of 181 participants. 20% was extra participants were added to compensate for bias and non-respondents. Hence, our final sample size was 217 participants. We had a total of 51.4 respondents out of the total number of students, which was 430. As for the study instrument, we had 2 parts. Part 1, which was the socio-demographic variables, and Part 2, which was the Beck Depression Inventory. As for the dependent variable, it was depression, and the independent variables were current cohort, age, gender, nationality, ethnicity, academic well-being, financial aid, and current relationship status. Our inclusion criteria included students who enrolled in the IMU MBBS program and students who are currently in semester 2 or in semester 5. As for the exclusion criteria, we excluded students who are currently receiving medical treatment for counseling, currently receiving medical treatment or counseling for depression. As for the study population, as mentioned earlier, it was semester 2 students and semester 5 students who are in IMU, and the total number of students in semester 2 and semester 5 were 200 and 230 respectively. We used a convincing sampling method, and as for the data collection procedure, a questionnaire was written out using the Google Forms software. This form was then distributed to the semester 2 and semester 5 cohorts via WhatsApp groups, as we could not interview them face-to-face. Students who were willing to participate then clicked on the questionnaire link and responded. As for the data analysis, the statistical package for social sciences version 27 was used. The quantitative variables were mean and standard deviation, whereas the qualitative variables were the frequency and percentages. The inferential statistics was at 95% CI values. Next, I'll be explaining more about the BDI. It contains 21 questions, and each student is scored from 0 to 63. Each question has a score of 0 to 3. So these are the cutoff points, as you can see. And students who scored 16 points or less were classified as not depressed, and students who scored 17 points or above were classified as depressed. Now we'll move on to the results. Table 1 shows the socio-demographic variables. It's pretty straightforward, but I'd like you to pay attention to the relationship status. So 26.7 students are in a relationship, so that's 59 students. And out of these 59 students, 35.6 of them have reported to have relationship problems within the past week of completing this survey. Now we'll move on to the prevalence of depression. In our study, you can see that there's 25.8% of students who are depressed, whereas 74.2 students are not depressed. Table 3 shows the prevalence of depression among the two cohorts. So you can see that ME119, the semester 5 students, have a higher prevalence of depression compared to ME220, the semester 2 students, with only 20.9%. Now we'll look at Table 4, the prevalence of depression. 57.5 students are categorized under normal, while 16.7% have mild mood disturbances. The rest are considered as depressed. So in Table 5, you can see the degree of depression among the depressed. It's pretty straightforward. Lastly, we'll look at Table 6, the determinants of depression using the BDI. So as you can see, students in ME119 in semester 5 are 1.67 times as likely to be depressed than students in ME220, the semester 2 students. Next, you can see the gender. The females in the study are 1.78 times as likely to be depressed than the males. Next, you can see the academic pressure. Students who face academic pressure are 3.10 times as likely to be depressed than students who do not face academic pressure. And lastly, you can see that students who are in a relationship are 2.00 times as likely to be depressed than students who are in a relationship. So that's all from me. I'll be passing on to my colleague.
Hi, my name is Arush, and I'm going to be carrying on from my colleague. So as mentioned earlier, our study was based on a prior study conducted at the University of Putra, Malaysia. This study involved preclinical medical students and also used the Brecht's depression inventory, so the BDI scale as well. So in that study, they found that the prevalence of depression was 35.9% compared to 25.8% for us. And if we explore the results slightly more, we find that the cutoff point used in the UPM study was 11 on the BDI scale, whereas our cutoff was 16. So just the difference in cutoff can explain why one study had a higher prevalence of depression than the other. Similar to our study, the UPM study also found that females, those with academic pressure, Malay ethnicity, were all more likely to be depressed. So also looking at other studies regarding the same issue, we found one study in the US that found the prevalence of depression among preclinical medical students to be 15.2%. A study in India found that the prevalence was an alarming 49.1%. And finally, another study in Malaysia found that the prevalence of depression was 60% among preclinical medical students. These are all the other three studies involve different scales and different methods of assessing depression. So we cannot directly compare our results to theirs because each scale will come up with a different prevalence for depression. But however, all we need to pay attention to from all these different studies is that the prevalence of depression among medical students is quite significant. Moving on. These are the recommendations that we came up with. So as the prevalence of depression among preclinical medical students is quite significant, we believe that there should be an increase in health education and promotion about depression. This will help increase awareness among students and hopefully help them identify the risk factors early and maybe find effective ways of dealing with these before it progresses into the development of a mental health issue. Furthermore, we recommend that research needs to be conducted regarding depression in medical students. This will help gain a better understanding of the issue, which will lead to more effective interventions being employed. And finally, we also recommend more interaction between student mentors and students. This will help check up on students, especially during exam time, And also, the mentors can help students deal with their stress and maybe also recommend them to health professionals if they do see any of the symptoms of depression. And finally, next slide. These are the limitations of our study. So due to COVID-19 restrictions, a physical interview was not possible with the participants. So we had to use a questionnaire instead. A physical interview would have been a more objective way of assessing depression among students, whereas a questionnaire is slightly more subjective and it's all down to the student interpretation of the questions. Moving on, carrying on from the previous point, the use of a self-reported scale to assess depression is quite subjective to individual interpretation of the words. This leads to slight variations in the answers and responses from the participants. And finally, our sample was only limited to one private medical university in Kuala Lumpur. So our findings can't really be generalized to all preclinical medical students in Malaysia. Adding to this, our study only involved semester 2 and semester 5 preclinical medical students. A further study should be conducted involving all preclinical students across multiple medical universities in Malaysia or the world. Therefore, the results from that study can be quite generalized and the data can be extrapolated to a wider population. And finally, this is the conclusion that we came up with from our study. So we concluded that depression is a severe mental disorder that shouldn't be taken lightly. And we found that the prevalence of depression among preclinical medical students at IMU in semester 2 and 5 was 25.8%. And we found that those experiencing academic pressure, those that were single, those that were female, and also international students, were all at a higher risk of developing depression. And finally, we recommend that further research should be conducted about this issue so that effective interventions can be employed. Thank you so much. This was our presentation. The next slide just covers some of our references. And if you have any further questions about our study, don't hesitate to ask us. Thank you so much.
Thank you, Mr. Abhijit and the co-presenters for a very interesting presentation. We would like to take some questions, and the judges, Dr. Nadia and Dr. Farzana, and the audiences now can ask questions. Yeah, you're welcome.
Yes, Dr. Nadia, you can go ahead.
Okay.
Yes.
Okay. So hi for the presenter. Thank you for the presentation. So for this study, it only involved the preclinical students, right? So as we know in medical school, right, there is a lot of stress in terms of worrying about the academic performance, right? And then a lot of exams, right? And then managing the expectation even from themselves and also the family. So in this case, do you think is there any much differences in terms of the depression if you compare preclinical and clinical students, right? Why you are focusing more on the preclinical students?
Okay, so I'll take this this question. So obviously for our situation, all of us were preclinical students. So when we were deciding of trying to choose a research project, we wanted to explore results that would apply to us and our situation. So that's why we were leaning more towards preclinical. But we do think there will be a difference between preclinical and clinical medical school, obviously because the workloads are different and a lot of the work and our daily day-to-day activities vary quite significantly between preclinical and clinical medical school. Because in preclinical school, we're mostly in class, we have some limited hospital exposure, but the majority of our time is spent learning content, going to labs, different classes, tutorials. Whereas if you compare this to clinical medical school, obviously we'll spend most of our time now in hospital settings, so more in clinics. And I feel like due to the change in circumstances, there are unique I guess, difficulties experienced by both groups of medical students. So based on the difference in situation, it can also result in different prevalence and incidences of depression among the two groups. I hope that answers your question.
Okay, thank you. So, which one you think will have more mental health issues, preclinical or clinical? If you just want to, you know.
Okay, so in this sense, obviously, I'm just going to speak my opinion about the issue. Obviously, like we need concrete evidence to support the claims I'm making. But in my personal experience and what I've seen so far, I do feel like preclinical medical students will have a higher prevalence of depression. And I'm only saying this because the jump from high school and undergraduate study to medicine is quite significant. So the change in workload, the sheer volume of content we're expected to learn, and also the sudden change in environment is more, I guess, immense when going into medical school compared to going from preclinical to clinical studies. Because hopefully, if we've done our job well during preclinical school, the jump to clinical studies isn't as intense just because we've learned our content, we've practiced our OSCE. So when we go into a hospital environment, it's not completely foreign to us. Whereas going into medical school initially can be quite daunting to some. Again, I hope this answers the question.
Okay, thank you. Dr. Farzana?
Yeah, thank you so much, Arush. You must have gone through the literature. Okay, while going through the literature review, did you find any studies about the differences between this stress and depression and these conditions, mental stress, between public and private universities? Did you come across any studies which have been done to compare these parameters between the two,
Yes.
public and private?
Yes, doctor. We did come upon a few of these studies,
Mm-hmm.
but obviously in our scenario, we didn't focus too much on the difference. So we almost we didn't exclude the studies, but we were focusing more on studies, focusing purely on preclinical medical students.
Mm-hmm.
So if you just go back into the presentation, I think there was one of the studies we mentioned. So the main study that our whole report was based on, that was conducted on a private medical school in Malaysia. So I feel like maybe our studies might be a bit more representative of private medical schools. But in saying that, we didn't seek out to find the difference between private medical school and government medical colleges. I hope that answers the question.
Yeah, it will be better if you could have compared private medical schools, if it has been done. It might have been done definitely between different private schools, so it would have made it much better. Anyway, that's just a comment. And you took 3 days to collect the data, right?
Yes, that's true, doctor.
Just 3 days. So maybe wouldn't it be better if you would give longer time period to and include the interviews when you go next time? So what is your thought about it?
So, doctor, this whole project or study was part of our syllabus. So in our timetable, we had a very rigid schedule to complete the study and present the results. So based on the constraints we were presented with, this is, I guess, the best we could do given the circumstances. However, yes, in the future, if the study was to be conducted again, we would definitely love to have more time, involve more students, and maybe even reach out to multiple medical schools so that the study we get is, the results we get are more conclusive and a bit more concrete.
Yeah, because I don't think 3 days are sufficient enough to.
Exactly, yeah.
Okay. Thank you. So,
thank you.
Yeah, back to Dr. Umesh.
Okay, Mr. Abhijit, we still have few questions. It's displayed on the screen. So I will take first question. Maybe Abhijit, you and your co-presenters, anyone can take up one, and one of the volunteer can answer. So I'll read first question for you. Under recommendation, you suggested increase in health education. how can health education create awareness of mental health?
Hi, so my name is Harishra, and I'd like to apologize because I can't turn on my camera. My webcam is not working.
Yes, no.
Okay, so I'll take the first question. I'd say increase in health education, it will definitely help students who are undergoing problems such as depression or anxiety. Some of them may not know the common side effects, the common signs and symptoms that is usually faced. And in some students, I'd say there's different signs and symptoms, like it's not a fixed list of signs and symptoms you see in each student. So I'd say by increasing health education, like having forums or like presentations or like sessions with your mentors where they go through like screening questions, I'd say it will make students more they'll be more aware of what they're going through, and then they can see whether or not they're having such problems. I hope this answers the question.
I hope that if you have still further inquiry on, there will be you can post in the forum.
Yeah.
Well, I'll go to the
I'll continue.
Okay, you want to continue with the next question?
Yeah, I can take the second one as well. Can the study be biased if the sample is? Oh, sorry. Thank you for the presentation. If there's specific reason to conduct, because I think. Sorry, the question disappeared, but I think it asked why it was done in preclinical, is it?
Yeah, I think this
it's
is
the same question.
This is the
It's
same question.
on
Thank
the
you for the
screen.
presentation. Is there any specific reasons to conduct this study, particularly in medical students?
I think there's no specific reason, but like Arush mentioned earlier, this was like part of our curriculum. So we were doing, we had to do it like as part of our uni like requirements. So we did something that would be related to us, and I think it was easier for us to collect data from medical students. As we like mentioned earlier, we sent out the questionnaire in our WhatsApp groups. So given like COVID and everything, we couldn't go out and interview patients, and the only way to reach them, like our respondents was through social media. So we chose WhatsApp, and yeah, so I think that's why we chose like particularly medical students. It's easier for us to reach out in such a short time frame.
Yeah, especially during the COVID time, I think.
Yeah.
Okay, so I'll go through another question down there. Anyone from your group can take up. So I'll read for you. Can the study be biased if example limited to only preclinical students? And can the result used to reflect the entire medical students?
Okay, I'll take this question. So based on like the parameters of our study, I think our results are only generalizable to preclinical medical students because that's who our study population was. So I'd say to answer the question, the study in a sense is biased towards preclinical medical students. So we can't generalize the results to medical students as a whole. Yeah, I hope that answers your question, Doctor.
So that was the forum question. I hope that the one who posted might be satisfied with the answer, or if you still have. Okay, I'll go to the last question. If there is any specific reason to select two groups in your study? If yes, then why?
All right.
Maybe any one of you can take it.
Okay, I'll take this one. So if we just go back a little bit, we did mention there was like a bit of a, I guess, time frame that we had to work within. So given the time constraints, we decided to try our best to represent the preclinical medical school cohorts. So generally preclinical students study for maybe 2 to 3 years in preclinical school and then move into the clinical medical school. So we use two groups, one to represent first year medical students and one to represent medical students at the end of their preclinical stage, so at their final semester. So just because of the resources constraints, we decided on two groups on either end of medical school spectrum. like preclinical medical school spectrum, so that we can at least compare two groups within the preclinical cohort. So again, see if there's any difference between students at the beginning of preclinical school and students at the end of preclinical school. Hence why we have those two groups. I hope that answers the question.
Okay, thank you, Mr. Abhijit and the co-presenters and attending this.
Yeah, sorry for interruption once again. Can I do one announcement?
Oh, okay, sure.
Yeah, so this is for all the presenters. Do join our last session, the closing ceremony, because there will be prize announcement for the best undergraduate student oral presentation, and you all aware of that you have a big prize for that. At the same time, I like to just remind our judges to submit all the scores online, and the links, Google Form link has already been forwarded. So before 5 p.m. so that we can finalize these the best oral presentation under undergraduate student category. So just that, thank you very much. So please join our closing ceremony. Over to you, Dr. Umesh.
Okay. So I was on the way thanking Mr. Abhijit and the team. All the best. Okay, now I would like to welcome our fifth oral presenter, Mr. Janardhanan, a student from National Defense University of Malaysia, to present his study on smartphone addiction and depression among NDUM students. I would like to invite Mr. Janardhanan to present their research. Welcome, Mr. Janardhanan.
A very good day, ladies and gentlemen. My name is Janardhanan from the National Defense University of Malaysia, and today I will be presenting about smartphone addiction and depression among the public university students in Malaysia. We realize that the addiction to smartphone usage is actually a common problem among students worldwide, and this can be seen as a risk factor for depression, loneliness, anxiety, and also sleep disturbances. University students spend most of their time with smartphones either to study or to socialize. In fact, smartphone has become a daily necessity for most people for its convenience in accessing information, social connectivity, workplace apps, and also entertainment, as reported by Ovido and Traspalacios et al. In the year 2019. The typical symptoms of smartphone addiction include both psychological and physical dependence. Psychological, namely craving, salience, and loss of control, whereas physical, namely tolerance and also withdrawal, as reported by Panova and Carbonell in the year 2018. Interestingly, according to the Malaysian Communication and Multimedia Commission in the year 2017, nearly 90% of adolescents and young adults are smartphone owners, which makes this research even more applicable and important for us to assess whether are they addicted to their smartphone or not. And also, is there a risk for depression, loneliness, anxiety, sleep disturbances, which brings us to the objectives of our study for today, which is firstly, to measure the level of smartphone addiction and depression, and second, to assess the association between addiction to smartphone usage and self-reported depression. The third objective is for us to identify the predictors of depression among the National Defense University of Malaysia students population. As for the methodology, we have chosen a cross-sectional, questionnaire-based, self-administered study design, and we conducted the entire research within the vicinity of the National Defense University of Malaysia. The population is none other than the National Defense University of Malaysia's student body itself. And we have only included the undergraduates, diploma and foundation students of the National Defense University of Malaysia. However, we have chosen to exclude the postgraduate students of UPNM. Why? Firstly, the difference in campus life between the undergraduate, diploma and foundation students and also the postgraduate students. You see, the postgraduate students do not live on campus and they are also mostly part-time students compared to undergraduate, diploma and foundation who spend all their time on campus and are full-time students. Secondly, the workload faced by a postgraduate student is obviously more heavier compared to the undergraduate, diploma and foundation, taking into consideration the family aspect of the postgraduate student, their outside jobs and so on, looking at the fact that they are part-time students. And secondly, the nature of their studies for postgraduate is more research-based, whereas for undergraduates, it's still assignment and also exam-based studies. Therefore, taking these two aspects into consideration, we have taken the choice to exclude postgraduate students from our study. As for sampling methods, we have chosen an internet-based unrestricted self-selected survey method. So what we did was basically we sent invitations to participants to take part in our study through common social messages such as WhatsApp, Telegram, Messenger, and a few, and so on. And also, we asked for the assistance of student bodies such as the National Defense University Student Council, which is actually the head of all the students in this university, including diploma and foundation students. Why? In order for us to have a wider reach to students and to get more responses for our study. The study instrument that we used was the Malay versions of validated questionnaires on smartphone addiction, also known as smartphone addiction scale, and also depression for Beck's depression inventory. The responses to smartphone addiction scale that we used, which is the short version, were rated on a 6-point Likert scale, and their percentage mean score was commuted and also categorized. However, for the response to the Beck's depression inventory, 20 items that we used were summated from a score of 0 to 60. The higher scores indicate a higher level of addiction and depression. For data collection, the study was done in August 2019 in the span of 1 week. And it is important to note here that during that period of time, a lot of students from the undergraduate and also foundation were going through some form of test, be it their final exams or their mid-semester exams. So luckily for us medical students, we were in our elective posting at that period of time, which we utilized to conduct this research. We did 2 days of discussion and finding sources. We used 3 days to collect data through internet-based questionnaires, and we spent another 2 days to analyze the data. As for the analysis, these data were analyzed descriptively by frequency counts, percentage and means, and the association between variables were measured by independent samples, t-test and one-way ANOVA. Also, a multiple linear regression model was introduced to identify the predictors of depression. As for the ethics, participation was voluntary and anonymous, with the assurance about the confidentiality of the participants' info. We did not ask for any private and confidential or individualized information from any of the participants, be it their name, email address, metric numbers, or whatever. All we needed was information required for us to categorize them according to social demographics. So the participant social demographics are as following on the pictures that you can see. As for gender, there were more males than females, whereby males were 54.8% of the participants, whereas females were 45.2%. This is correct in the National Defense University of Malaysia setting, whereby there are more males than females in this particular university, looking at the fact of its military base and also a very high activity nature of this university. Whereas for race, 85% were Malays, Chinese were 4.6%, Indians were 7.9%, and the other races were about 2.5%. This is a good representation of the races in this university, which could also represent the races in our society or country as a whole. Why? Because Malays are still a majority, followed by Indians, Chinese, and also the others. For the year of study, 37.8%, which is the majority of students, came from the foundation group. whereas the first years were 27.4%, second years were 27.8%, third years were 5.4%, whereas the final years were only 1.7%. Another reason for the final years being 1.7% was the fact that most of them were at their internship and also their industrial training at this period of the year. And education level, 52.7% were degree students, foundations was 37.3%, whereas diploma were only 10%. So let's look at the results that we have found, which are quite interesting. You see, for smartphone addiction scale, we found that only 4.6% of students were not addicted to their smartphone, whereas 75.9%, a majority of them, admitted to be slightly addicted, and 19.5% admit that they are addicted to their smartphones, making it a total of 95.4%, vast majority of students who were addicted to their smartphones. The percentage mean total scores for smartphone addiction were 56.1, with a standard deviation of 16.5. As for depression, on the other hand, we can see that 60.2% or majority of the students claim to be normal, whereas 15.8% admitted to having mild mood disturbances. 10.4% came under the borderline clinical category, whereas 7.5% were moderate depression, 4.6% severe depression, and an alarming 1.7% showed signs of extreme depression, making it a total of 39.8% of students showed some signs of depression. The mean total scores for depression is 10.3, with a standard deviation of 10.23. So what did we conclude from our results? We found that smartphone addiction and female gender were significant predictors of depression, and participants predicted depression level increased by 0.111% mean scores for each PACS depression score. Also, being a woman apparently increased your depression scores by 2.836 compared to men, noting that actually being a female and also having an addiction to your smartphone are predictors to depression according to the results of the studies. So what we could discuss about this is when we look back at a study done by Tommy et al. Entitled Mobile Phone Use and Stress, Sleep Disturbances and Symptoms of Depression Among Young Adults, which was conducted using a prospective cohort study design in the year 2011, found that smartphone addiction was associated with sleep difficulties and depression during a one-year follow-up, even after excluding participants with mental health problems at baseline. In fact, a similar study conducted by M. Kim, H. Kim, K. Kim, S. Ju, J. Choi, M.U. in 2016 found significantly positive correlation between smartphone addiction and depression among college students in Cheonan, Korea. It is also concluded that young people rely heavily on their smartphones to conduct their daily activities as well as to keep in touch with other people. This was conducted by N. Mayudia, who was a researcher from the University Putra Malaysia in the year 2016. So these three researchers can actually show us that the results of our research correlates to the results that have been to the researches that have been conducted before, to show that actually smartphone addiction does have some role in depression. However, we are still unsure whether does smartphone addiction cause depression or does depression cause smartphone addiction, which is why we have come to the conclusion that the addiction level towards smartphones and the level of depression among the students in NDUF were high. But the relationship between depression and smartphone addiction is an escalating global concern which necessitates future studies to investigate further on this aspect, looking at the fact that the relationship is actually a complex relationship. So, in order for us to really understand how one affects the other, we need more studies and we need more research into this particular matter. Last but not least, a friendly reminder to everyone. Cell phones bring you closer to the person far from you, but unfortunately takes you away from the one sitting right next to you. These are a few pictures taken of the situations in this National Defence University of Malaysia, obviously before the movement control order and the COVID pandemic, whereby we can see that even in groups of people, cell phones still are the ones people pay attention to. What more when they are alone, they lose track of their surroundings. With that being said, thank you.
Surely mobile phones are an addiction. Yeah, okay, thank you, Mr. Jana, for a wonderful presentation. Now, I would like to call upon judges to ask a few questions, and audiences, they can post their questions on the screen. Yeah, Dr. Nadia and Dr. Farzana.
So, okay, hi, thank you, the presenter, for the presentation just now. So, for me, I would like to know what is the limitation of the study?
Good morning, Doctor. Good afternoon, Doctor. I'll take that question. As for our study here, one limitation would be the time frame itself for our sample collection, whereby we could have had, if we had a longer period of time, we could have collected more sample and done the study face-to-face with the students. However, due to the very short period, which is only 1 week, we had to do it as an online survey study. Another limitation that we could see is how Beck's depression inventory that we used is actually a screening tool for depression. And this study, however, is still not enough for us to detect the level of depression among the students in order for us to take preventive measures to treat or to help them before their depression worsens and mental health issues escalate among the students, Doctor.
Okay, so I see from your presentation, the findings, you found that about 39.8% of students having depression, right? From mild until severe, isn't it? Right, in your study?
Yes, Doctor.
What do you, I think, okay, 39.8 having depression and also 90.5% having addiction, right? Addicted to smartphones. So did you do any follow-up on them after the study?
That's the thing, Doctor, because since the study was done anonymously in order to protect their identity, so we don't exactly know which student has that depression scale. So in an overall setting, the students, someone in the group of students that we have investigated are having the tendencies to be depressed. This is why if we had more time to do a larger scale of study, the results would be more efficient, as we could use it to collaborate with the counseling department or psychiatry unit in order to create a preventive program to further detect the students in a more clinical setting and take the necessary preventive measures.
Yeah, I think because the number is quite high in your finding, right? 39.8%. So I think that you, I mean, when you are collecting the data, you can also offer some help for the students because they might not know what to do if they're having depression, right? I think that's all for my part.
Yes, Doctor. Thank you.
Okay.
So yeah, Jana, thank you so much for the presentation. Very interesting study indeed. So I would like to say just one thing, that this addiction also helped you to get your data for your study. So anyway, so I wanted to know what is the criteria for labeling them slightly addicted and addicted. What was the criteria to differentiate between slightly addicted and addicted, like you have shown in your results?
So like I said, we used the smartphone addiction scale. It was a 6-point Likert scale, like I mentioned. So as we got them, the scores that, let me just check the scores again, because this was done 2 years ago, so it's a bit cloudy.
Okay. So because most of the students, in your scale, in your graph, it showed that they were slightly
addicted.
So I was interested to know who were, what was the criteria to put them in these categories, slightly addicted and addicted.
So I think basically it was just the scale itself, Doctor. There was a certain margin for each of the scores, you see.
Mm-hmm.
So for slightly addicted, it would have been maybe in the middle margin, from ranging from 3 or 4 to from 3 to 4 and things like that. But I'm very sorry, Doctor. I really should go check back the Likert scale.
Okay, never mind. So what is the relationship of depression? Like which was the group which was more, in which you found there was more higher prevalence of depression, whether it was the group which was labeled as slightly addicted or the addicted group? Did you find out the relationship between these groups?
Yes, Doctor. So we did the regression using the SPSS. We just found that basically the ones who were addicted, like the most addicted ones, not like the truly addicted ones, they had a higher tendency to be depressed. Another predictor that we found for depression was from the socio-demographics, whereby the girls itself had a high tendency to have depression when we did the regression using SPSS, the linear regression.
Thank you. That's all from me.
Sure.
Okay, Mr. Jana, I don't think there is any questions from the audiences. I would like to just by curiosity, is there any mechanism in your university who deals with behavior problems or addiction problems?
Yes, actually, Doctor, this university is very different from every other public university because of its military setting, you see. So mental health issue is one of the biggest concerns here. And even our counseling unit is very closely related to the psychiatric unit for Hospital Angkatan Terkuan Design. So every year, there would be a minimum of at least 3 to 4 programs whereby they screen students for depression and addiction. And also they would take the effort to go through the social demographic or the background of each student to find any stresses in their life, for example, loss of parents, in terms of financial, weak studies. And as soon as they find this, even a single predictor that something will go wrong with their mental health, they will immediately call the student in for counseling and develop a specific program for these students. So this has been happening since I was in foundation, and now I'm in my 4th year. I myself have been to these programs twice, I think, due to the military training and all. See.
Okay.
So that's how they cope.
That's great. Actually, it's a good mechanism. After doing your study, I think it is already 2 years. You have completed your study, and did you bother to inform this kind of authority that yes, I have this data collected and it's a concerning data to any authority in your institution? Have you reported this?
Yes, yes. Actually, in the year 2018, as soon as the data came out and we have collected it, our supervisor at the time, Associate Professor Helena, she immediately informed in the management meeting that they usually have every month, if I'm not mistaken. So this issue was already there, but it's already a concern even before the study was done.
Okay. Was there any action taken for that?
Like I said, Doctor, because it's already a mechanism in place, so I think they went by with the same mechanism that they might have had. However, if my memory serves correct, in 2018, November, if I'm not mistaken, it was semester break or something at the time for foundation students. So they did do a small mental health program with the foundation students at that period of time, just to help them cope from the transition from foundation to degree. But
okay.
If I can still look at it.
Yeah, thank you, Mr. Jana, for a very nice presentation and a really interesting one. And I hope you will do some more studies like this in the future. Thank you so much.
Thank you so much, Doctor.
Okay, I would like now to welcome our 6th oral presenter, Mr. Tilanka Tilakratne, a student from Medical School, Taylor's University, to present the study on association between stress, anxiety, depression, and quality of life among B40 community. Welcome, Tilankana.
A very warm welcome to everyone. My name is Tilanka Tilakaratne, and I'll be representing Team 6 to present our paper titled Association Between Self-Perceived Stress, Anxiety, Depression, and Quality of Life in a Malaysian B40 Community, a cross-sectional study. The other group members are Kishan Kumar, Nimesha Tilakaratne, and Rishan Charles Rizali, and our supervisor is Dr. Sapna Sridhar Patil, who is a senior lecturer at the Faculty of Health and Medical Sciences from Taylor's University. So just to outline the context of this presentation, I'll be starting off with an introduction to outline some definitions, followed by a literature review, and then we'll discuss the methodology and results to end with a conclusion and some recommendations. So to begin with, what does B40 stand for? So in Malaysia, B40 stands for the bottom 40%, which comprises of low-income earners, and according to the Household Income and Basics Amenity Survey report done by the Department of Statistics Malaysia back in 2019, this population comprises of 2.91 million households with a median income of 3,166 ringgit per month. Now, as you can see, this is a stark contrast to the median incomes of the middle 40% and top 20% in Malaysia. So when we talk about quality of life in this study, we use the definition put forward by the WHO QOL group back in 1995, where they defined QOL as the individual's perception of their position in life in context of the culture and value systems in which they live, and in relation to their goals, expectations, standards, and concern. And when we talk about mental health, we use the definition put forward by Mary Jahoda back in 1958 in her construction of the concept for positive mental health, in that mental health is the capacity to realize one's own abilities, cope with normal stresses of life, work productively, and make a contribution to their community. So the research gap that we identified for this study was that, to the best of our knowledge, there are no studies at present on the association between quality of life and mental health state in low-income urban populations, especially in Malaysia. This led to our objective, which was to study the association between self-perceived stress, anxiety, and depression, and 4 domains of quality of life, which were physical health, psychological, social relationships, and environment, in adult residents living in PPR Seripantai, which is a B40 community in Malaysia. So the significance of this study was to ultimately contribute to the body of literature from which evidence-based policies can be developed to address the socioeconomic and health disparities in the B40 community. So moving on to the literature review, we conducted an extensive review of literature, and in this presentation, I'll be showing some of the more recent and congruent studies to keep in with time. So the first one here is by Isabel Matute et al. This study was done in Chile. And one of their key findings was that the probability of poor health-related quality of life was in fact higher in worse socioeconomic strata. And how this relates to our study is that the effect of socio-demographic factors and socioeconomic status on quality of life was measured. And a key difference is that they used the short form health survey, or the SF-12 questionnaire, whereas we used the WHO QOL breath questionnaire. Next, we have a study by Sharifa Izzatwan Puteh et al. This study was done in Malaysia, and their key findings were that low quality of life was associated with being male, single, low household income, and presence of chronic medical illnesses. And how this study relates to ours is that it was in fact studied in the bottom 40 population in Malaysia. And how this differs is that they measured quality of life using the Euroqual 5D questionnaire and not the WHO QOL breath questionnaire. This next study was done by Mohsen Mirzai et al. This was conducted in Iran. They used the DAS questionnaire, or the Depression, Anxiety, Stress Scales questionnaire, to measure these 3 subscales of mental health. And how that differed from our study is that the study was done on a population that was not specifically low income. This study by Najmi Rabanipour was also done in Iran. It was conducted in 2018. And they showed that there was a significant association between mental health and quality of life, such that people with good mental health status had a higher quality of life. How this study relates to ours is that they investigated the relationship between mental health and quality of life, and it differed in that they used a different questionnaire to measure quality of life, which was the Eurocore 5D, and the study was actually conducted among industrial employees and not necessarily low-income earners. So moving on to the methodology, the study design and population, we conducted a cross-sectional study among the residents of PPR Serpentine. Now, PPR Serpentine is a low-cost housing scheme that was developed by the government back in 1998 to provide affordable housing to low-income earners in Malaysia. Now, this particular block of apartments consisted of 2 towers, each 21 floors high, and about 400 households each, and they accounted for around 4,250 residents. For our study, we particularly selected respondents to be 18 years and above, so adults. And these 2 blocks consisted of our sampling frame. The sampling method that we used was convenience sampling. Now, this was due to a variety of reasons, which included the current pandemic that we're under, and also the time and cost restrictions for the study. The sample size was 107 respondents, so we had 55 respondents from block 100 and 52 respondents from block 102. We chose these respondents by sending out text messages through WhatsApp with the links to online surveys, which they could conduct remotely from their homes. And we also had a designated day later on where respondents could come in and complete the surveys with the aid of some data collectors to go through the questionnaires using electronic devices. So the study instruments that we used for this device was the validated Malay version of the World Health Organization Quality of Life Brief Questionnaire, or WHO QOL Brief Questionnaire for short, and also the validated Malay version of the Depression, Anxiety, Stress Scale, 21 items, or DAS-21. So briefly about the WHO QOL Brief. This questionnaire comprises of 26 items, of which 24 items are divided into 4 domains, which are physical health, psychological, social relationships, and environment. And these domains were incorporated with facets from the original WHO QOL 100 questionnaire. All items are rated on a 5-point Likert scale from 0 to 5, or lowest to highest. There was some reverse scoring that was done later in the analysis part, and the total scores were transformed to be out of 100, so it was comparable to the original WHO QOL 100 questionnaire. Next, we have the DAS-21 questionnaire, which comprises of 21 items, equally divided across the 3 sub-scales of mental health, which were depression, anxiety, and stress. Each item was scored between 0 and 3, and the scores for the 7 items for each subscale were multiplied by 2. So to ultimately give you a range between 0 and 42, which was comparable to the original DAS-42 questionnaire. And these scores can be ranged between normal to extremely severe, depending on each range for the subscales, as shown in this table here. So we used SPSS to statistically analyze the data that we have collected. First, we conducted a descriptive analysis to obtain the frequencies among the socio-demographic characteristics, so a distribution in a sense. And we found out that the majority of the respondents, or 76.6%, were within the 31 to 60 years age range. And 84.1% of respondents were female, and also 86.9% of respondents were Malay. As for marital status, a majority of the respondents were married, accounting for 59.8%. And also the majority had only completed up to secondary education, which accounted for 74.8%. As for employment, there was almost an equal distribution of employed and unemployed, and we account for this high unemployed number that from that we did carry out data collection on a Friday for this particular study, and also that the majority of the respondents were female and also housewives, which were not included in the employed category, but rather unemployed category. Next, we looked at the mean scores for both questionnaires, so the DAS-21 and the WHO-QOL-BREF domains questionnaire. And we found that the average score for anxiety actually placed an average of the respondents in the mild anxiety category for this. It's important to note that the DAS-21 isn't a clinical tool, therefore being placed in the mild anxiety category here isn't clinically evidenced, but more or less to put them on a continuum for the sake of the scale from 0 to 42. And then the stress and depression average scores placed these respondents in the normal category. When we looked at the WHO-QOL-BREF scores, the highest average score was for the physical health domain, and the lowest average score was in the psychological domain. So next we conducted a Pearson correlation test to test the strength and direction of the relationship between the 3 subscales of mental health and the 4 quality of life domains. And as you can see in the table, we found across the board that we found a negative correlation between the 2 variables. Of particular note, the strongest negative correlation was between social relationships and stress, anxiety, and depression, where we found a negative, medium, moderate correlation. And the correlations were set at a significant level of 0.05. And the correlation between environment and depression, although it was negative, was found to be not statistically significant. And here we have a series of scatter plots which depict the correlation between social relationships domain and the subscales of DAS-21. And as you can see, there is a linear negative correlation with the data points clustered around the line of best fit. As for limitations, the first one, as I mentioned before, was the cross-sectional nature of the study. So the study does not allow us to find a causality between the variables that we measured, but more of a correlation. Next, the relatively small sample size. We only managed to get 107 respondents, which was above the minimum cutoff of 100, but we would have liked more. So future studies, we would like to incorporate a high number of respondents. And also the use of convenience sampling, which isn't ideal as it is a non-probabilistic and non-random method of sampling. And we had no control over the selection of the criteria for the sampling method. So in conclusion, we discovered that there was an inverse relationship between quality of life and mental health subscales, and also that from the 4 quality of life domains, social relationships had the strongest negative correlation with stress, anxiety, and depression. And therefore, our recommendations are further in-depth studies to be conducted to determine a causal relationship between quality of life and mental health in the form of longitudinal studies or qualitative studies, and to develop evidence-based policies in addressing the socioeconomic and health disparities in the B40 community, so that, as per the 11th Malaysia Plan, that no one will be left behind. These are our references. Thank you for watching.
Thank you, Mr. Telanka, for a very interesting presentation. We will now take some questions from our judges, Dr. Nadia, Dr. Farzana, and audiences can post their questions by scanning the QR code. Your questions will appear on the board. Thank you. Yes, we off to the judges.
Dr. Nadia, where is she?
Okay. Okay. So thank you, presenter, for the presentation. So from the your study just now, it was mentioned that majority of the participants were female, right? So do you think it's representative of the community in the PPR? Because I've seen that the numbers of the, I mean the occupants are more than 4,000, isn't it? So is it representative of the population because majority of the participants are female?
As for being female, because we use convenience sampling, we can't really ascertain whether the proportion of females is correct in our study. But some of the things that did categorize was the timing of the survey was done on a Friday and at home in their residencies, and most of the men, we believe, who were employed were not at home during the time of the study. So that may have also caused a skew in towards having a greater female population.
So okay, so thank you. But right. How do you think that you can improve and make the result more generalized to the PPR population?
That's a good question, because we did do this study as part of our syllabus for the community medicine posting last year in August. And we had to face a lot of obstacles during the time. As you all know, the pandemic had come up, and then we also had this time constraint of about 3 weeks from start to finish to get this study done. Ideally, we wouldn't have, we would not prefer to do a cross-sectional study, but maybe a longitudinal or qualitative study, so that we can perhaps identify the correlation rather than the causation rather than the correlation. That would be the improvements that we want to do. Additionally, the sample size, we managed to meet the suitable 100 threshold for a study. However, again, the more the better. So we would have liked to have more time to reach more participants and allow more participants to participate in the survey.
So, okay, thank you. I think if you do the study, if you collect the data not on the weekend, maybe you can gain I think gain more respondent, because your respondents are majority are the housewives only, right? Not the breadwinner, from the breadwinner, with the men who are working, right? So,
yeah, definitely.
Right. Okay, that's all. Thank you.
Up to Dr. Farzana, you have a question for Tilanka?
Thank you, Dr. Nadia. Thank you, Tilakna. Good to see you.
See you too, Doctor.
Yeah. So yeah, I also had the same point. I had noted down that most of your respondents were females. So I wanted to ask you why most of them, 84.1% were females. So it doesn't represent the population.
No, it doesn't. Yeah. Again, it comes down to the limitations of the sampling method that we used.
Yeah. So it doesn't represent really. That is my concern. And then, you told me, I was about to ask that this collection of data was done during COVID-19 pandemic.
Mm-hmm.
So do you think that must have also affected the results of the study?
Yeah, we actually certainly...
The sense of well-being and everything?
Yeah, definitely. We wish we could have incorporated a few questions specifically on the COVID-19 that would have given a better picture of the current snapshot. But it was a weird time because it was during August. We were coming in and out of lockdowns, and
that would have been better had you included some questions regarding the COVID-19, how it has affected. And I have seen during this MEGOPIC, I was going through several papers, like Dr. Nadia also must have seen. There are quite few studies which have been done on B40 communities. So I just wanted to know, out of curiosity, so after doing these studies, is there anything you people could do or influence the well-being or the upgrading of these communities in any way? possible? What is the result of these studies?
Yeah, so I think the major aim for our study was to highlight the importance of mental health, because we feel that in terms of your overall health, mental health isn't a widely talked about subject. Sometimes it's taboo in certain cultures and religions. And especially the B40 community, we feel that while the government has implemented schemes and programs to help the B40 community specifically, we're hoping that studies like ours can feed into further qualitative studies that can actually help provide evidence-based policies. But the government is doing work currently, but there's always room for improvement anywhere.
Thank you. That's all from me.
Okay, thank you. Tilanka, we have a question on the board for you. I'll read for you.
Yeah.
So is there any language barrier during the survey? If yes, how did you overcome it?
So the questionnaires that we used were the Malay versions of the DAS-21 and the WHO-QOL breath questionnaires. So they were in Malay. Actually, Prof. Rusli is actually one of the professors who was responsible or involved in validating the Malay versions for the DAS-21, I think. As for the language barriers, for any participants who had difficulty in not necessarily the language, but in terms of how to interpret the statements, there was help offered by our group members at the time when we had these on-site questionnaire taking. We did help them translate and read through some of the questions.
Okay, there's no further question in the forum. I think that's all. Thank you so much for a very good presentation. And I would like to thank all the presenters for this particular session. Well, yeah, no doubt, novel coronavirus is widely spreading all over the world and is definitely causing mental health issues for most of the people. And the medical staff is also under considerable psychological pressure. I think there should be strategies to understand their concern and to address their mental issues as well. I hope it will be on the way and people are addressing it. Okay, so this is for the session particularly, and I would like now to invite my co-chair, Dr. Farzana from School of Medicine, to start off the next session to on the expert perspective talk. Over to you, Dr. Farzana. Thank you so much.
Well, thank you, Dr. Umesh. Without further delay, we will now move on to our expert perspective talk on the topic of pathophysiology of COVID-19. So our expert speaker for this part of the session is Associate Professor Dr. Fidel Fernandez, who will share his insight on pathophysiology of COVID-19. Dr. Fidel Fernandez hails from Mindanao Island in the Philippines, and he graduated MD in 1979 from Far Eastern University Institute of Medicine, Manila, and took his residency in pathology at the Far Eastern University Hospital. He is a fellow of the Philippine Society of Pathologists and an associate member of the International Academy of Pathology, Malaysia Division. He has a master's degree in clinical tropical medicine from Mahidol University. His experience in pathology includes a government position as medical specialist for some time, a surgical pathology consultant, and as chief of laboratory for more than 35 years. His academic involvement likewise has been uninterrupted for more than 35 years. His former position in the academia included being the academic dean of a medical school in the Philippines. So he is currently an associate professor in pathology at Segi University, Faculty of Medicine. So I would like to invite Dr. Fidel Fernandez to share his thoughts. Welcome to Dr. Fidel.
Colleagues in the medical profession, healthcare workers, medical students, ladies and gentlemen, hello.
First of all, I'd like to thank the organizers of this conference, Taylor's University, and the rest of collaborating institutions for making me a part of this conference. I was tasked to deliver a lecture that is easy to understand, designed for everyone to learn about the pathophysiology or the mechanisms of the disease called COVID-19. We have been waging war against this virus for about a year now. And it's about time that we should be able to educate not only medical people, but likewise for the general public. So I wish to be able to deliver this as easy as possible, as easiest way possible, that should be understood by the general public and the medical community. And I hope that the concepts that I provide here would be suitable for medical students especially, and also for the medical professionals. And I hope this should stimulate medical students, researchers to be able to get some ideas, especially those focusing on the progress of the disease called COVID-19. So let me go direct to the point. Let me introduce to you the disease, okay? Let me tackle the name. This disease is called COVID-19 for coronavirus disease of 2019. It is also called SARS-CoV-2. And CoV-2 refers to coronavirus number 2. And there's a reason why it's called corona. It's because of the spikes that the virus has on the surface, which resembles the crown. The spikes of the crown as well looks like the spikes that we see on the virus. It's also called SARS for severe acute respiratory syndrome. It's called severe because it inflicts serious damage to the tissues that it involves. It's also called acute because in medicine, the word acute refers to the onset, immediate onset of signs and symptoms, or urgent or sudden onset of the manifestations referable to this disease. It's called respiratory syndrome because the primary organ involved is the lungs. And it's a syndrome because other organs may manifest as well, such as symptoms coming from the brain, neurological manifestations, or from the heart, cardiovascular manifestations, or from the kidney, renal manifestations. Organ systems may be involved as well. And so that's the term syndrome. And so that's how it is, SARS-CoV-2. Now let me describe to you quickly a bird's eye view of what the processes are. So the processes are divided into 3 stages. The initial stages, which includes attachment, the multiplication of the viruses, the spread of the virus to other systems of the body. Then we have the second stage, which is the inflammatory stages, which is actually a defensive mechanism of the body. And then the terminal stages. So let me show you a diagram that describes the stages of the disease. In this diagram, describes the entry and the replication and how the viruses are released. Okay, in the circle that is shown in the slide, exhibits a virus attached to a receptor. The receptor is called ACE2 for angiotensin converting enzyme number 2. These receptors are found in our cells, very predominant, found in the respiratory system. It's also present in the cells that line the capillaries, what we call as the endothelial cells. Okay, so when the virus attaches to the receptor, the cell itself invites the virus into the inside, where it hijacks the mechanism of the cell itself. It corrupts the mechanism of the cell, thereby, instead of producing our own components, proteins, then the virus dictates the mechanisms of our cell to produce viral protein. Viral proteins are produced and assembled into a new virus. Now, mind you, every time a virus is released, it is accompanied by the death of the cell as well. So the number of viruses corresponds to the degree of destruction of tissues. It's directly proportional. So you see, in cases that are mild or without symptoms, in infectious diseases, it means that the virus has not reached a point where the amount of viruses affecting cells are able to produce a disease. That's what they call as minimum infectious dose. So in cases that are asymptomatic, it means that the virus is not enough, the amount of virus that enters into your system is not enough to produce a disease. You might have the virus, but then it doesn't progress. Mild and moderate symptoms are produced by viruses that are able to undergo a portion of their progress. Okay? And they are stopped because of a good immune system that we have in your body. Our own immunity would be able to arrest the progress of the virus, and then symptoms disappear. But in cases where there is overwhelming amount of viruses present, they multiply so rapidly, associated with significant amount of tissue injury. What happens is that the next stage progresses. So let me continue on. Let me dramatize the progress of the disease in this slide. So this is the virus, and I hope you can appreciate the corona surrounding the virus there. This is taken by an electron microscope. When it enters into the cell, they involve the respiratory system, because these respiratory organs here contain very significant amount of ACE2 receptors. Although other organs may be involved by virtue of the presence of receptors as well present in capillaries. But the primary disease that is produced by the virus in the lungs is called interstitial pneumonia. And I presume you understand what pneumonia is. It's a severe disease of the lung, and you're familiar with bronchopneumonia and lobar pneumonia. Bronchopneumonia and lobar pneumonia are names based upon the anatomical consideration of what part of the lung is involved. Like lobar pneumonia involves the entire lobe of the lung, because the lung is made up of lobes, and bronchopneumonia involves the air passage and the surrounding lungs around the air passage. In viral pneumonia, such as in COVID-19 pneumonia, the type is called interstitial pneumonia. Now, I want you to understand what interstitial pneumonia is. Imagine the lung like a cluster of balloons, and the cluster of balloons represent the lobule of the lungs, okay? The airway, the lobule, is made up of several balloons, and the balloons are filled with air, and the balloons are bounded by elastic rubber, very thin. But in interstitial pneumonia, what happens is that the inflammation is noted in the wall, in the balloon, in the membrane that holds the balloon together. So it thickens, it becomes like leather. And what happens there, okay? What happens there is it blocks the exchange of gases. Now, the anatomy of the respiratory system is designed to be such that the alveolar walls are thin because it contains capillaries, and the alveolar space contains the air that contains the oxygen. And there ought to be an exchange of oxygen and carbon dioxide at this level. In interstitial pneumonia, due to the virus, there is a block in the exchange of gases. And that's why the resulting condition would be what we call as hypoxemia, and that would refer to low oxygen level in the blood. Hypo means low, oxy means oxygen, emia means blood. Now we give oxygen. In many occasions, in any form of conditions, when the oxygen levels are low, we give oxygen and the oxygen is corrected. It goes back to normal. In interstitial pneumonia, it's progressive. Once the virus is able to attach and anchor to your system, it multiplies, it produces damage, it produces a block in the exchange of gases, producing hypoxemia. But as the disease progresses, more and more alveoli are involved, and it produces a hypoxemia that does not respond to oxygen treatment. No matter how you administer oxygen, the oxygen remains low. The levels of oxygen in the blood remains low. That's what a condition we call hypoxemia refractory to oxygen therapy. And that's the sign of the beginning of ARDS. What's ARDS? Acute Respiratory Distress Syndrome. There's the word acute, meaning it's sudden. There's respiratory distress because the main problem arises from the inability of the lungs to deliver oxygen into the systems of the body. And so there is difficulty of breathing. And it's a syndrome because oxygen is needed by all other organs. And if oxygen levels are low, for example, in the brain, then you would have neurologic manifestations. If oxygen levels are low in the heart, then you will have some chest pains or some signs and symptoms referable to other organ systems involved. And that is ARDS. Now, once we have this, okay, as the disease is progressing from the initial stages up to the inflammatory stages, okay, inflammatory stage is the second stage of the condition, where we have the defensive mechanisms that are activated, we call inflammation. And you know what? Inflammation is mediated. Okay, there is something that makes the inflammation proceed, and those are the mediators called cytokines. Okay, what are cytokines? They are protein produced by cells. Cyto means cells, kines taken from the word kinetic, which means activation. So in this stage, cells are activated like a domino, okay? One cell activates another type of cell. Another type of cell activates another cell. How do they do that? By releasing a particular cytokines specific for them. They release cytokine to activate other cells. And now, when the inflammation progresses, okay, more viruses are involved, more destructions set in, more tissue destructions occur, then there is a commensurate amount of inflammation that take place. How? By more cytokine being produced by cells. Now, up to a point where the cytokines are massively produced by cells, and they produce a cytokine storm, which means to say that the inflammatory response due to cytokines overwhelm the systems of the body. You see, the systems of the body consist of, all other organs of the body that would respond by having vascular changes and metabolic changes. And if it is overwhelmed by so much cytokine produced by cells, it would not be able to handle them. And what would happen? It would go to the next stage, what they call as DIC, disseminated intravascular coagulation. What's that? It's coagulation, blood clotting, intravascular, inside the blood vessels, in the circulation. And disseminated, it's not just one part, but it's all over the body, which means to say that clots of blood go along with the circulation, and what happens is that it may stop in one particular organ, like it obstructs the brain. Clot will lodge into the blood vessel of the brain, and it produces a stroke. Or it may go to the heart, it produces heart attack. Or it may go anywhere and produces obstruction, or what they call as infarction or embolism. And it's so easy to understand why multi-organ failure sets in. So this is the stage they call final stage, because it's so difficult to pull out the patient from this stage to a survival mode stage, okay? This is terminal stage, actually. When you have a patient at this stage, you're almost losing the patient, okay? So multi-organ failure, then eventual death. Let me tell you about what happens to the lungs, okay? This is a case of ARDS, just to show you the difference between the normal lung here and the ARDS lung here. And I'm sure that even just by looking at the picture, you would be able to appreciate the differences, okay? The normal lung is filled with air, with very thin walls surrounding it, you see? And we know that it is in this area, okay? The airspace and the capillaries that are found in the walls, where the oxygen and carbon dioxide exchange, the exchange of gases take place there. But when you have ARDS, you see, you have thickening of the walls. So the oxygen present in the alveolar spaces, you see, the alveolar spaces are still open. But unfortunately, the walls are so thick that the exchange of gases cannot take place. It is also due to the presence of hyaline, hyaline membranes that blocks the exchange of gases. This is what we see in acute respiratory distress syndrome. We may be able to see multinucleated pneumocytes. Okay, pneumocytes are the cells that line the alveolar spaces. We would not be able to see the viruses at this level of microscopy. But then we can see the evidences of the virus present in the pneumocyte because they become multinucleated. That's a kind of a reaction by the cells. They assume multinucleated types of pneumocytes. Then later on, bronchiolitis obliterans sets in. So the name implies obliteration of the bronchiole. You see, this is the bronchiole. And just imagine if this is obstructed, obliterated by changes that we see in ARDS. I'll show you what the changes in ARDS for you to be able to understand what's happening, okay? These are images, real images of COVID patients found in the internet, okay? I took these photos to be able to show you what the changes are. Okay, this is the initial stage, exudative phase. But even in the most initial stage, we can see that there is widening of the alveolar walls. And even in the early stage, we expect that there will be no exchange of gases taking place in this part of the lung with this exudative phase. As the condition worsens, see, proliferative phase sets in. And this is the phase where cytokine, you see, inflammation invites, one cell activating other cells, and they would invite other cells into the tissue, and they will flood this lung with cells and inflammatory debris and probably exudates rich in protein. Later on, fibrin will deposit into this tissue here. Fibrin is a kind of protein. And if you recall, if you know what fibrin is, it's the one that makes the blood to clot. And so fibrin deposits in the lung, and you see how much obliteration is taking place there. The lung is entirely obliterated. You see, the lung, the spaces in the lungs are gone. And it organizes, it becomes solid. You see, in the last stage, they become solid, they become organized. And I'd like you to see the picture of how the lung is organized in cases of pneumonia, interstitial pneumonia. Imagine a high, a soup, a liquid. It starts with being liquid. If it's rich in protein, just like soup, okay, you boil meat for soup, then you take the soup, put it in the refrigerator, and leave it overnight. And the following morning, you'll see that the soup has turned solid. They become gelatin-like, and that's the reason. That's organizing pneumonia, and the reason for what happens here is because of the high protein content present in the exudates, including the presence of fibrin. Okay, what changes happens in other organs? Well, most of them would show inflammatory changes that are immune mediated, okay, immunity or autoimmunity, cells acted upon by immune cells, okay, the viruses acting upon the body in the tissue level, and they would produce kind of inflammations all over. Okay, you may have myocarditis, and you may have encephalitis. You may have all the kinds of inflammatory changes in the different organ systems of the body. And of course, this is very much associated, as I mentioned, the concept is, okay, multiplication, the dose of the virus is very much directly proportional to the amount of tissue damage. The amount of tissue damage is directly proportional to the inflammatory response. The inflammatory response is directly proportional to the amount of cytokines. And so they are so much related with one another. And the cytokine is the one that heralds to the final stages. And so that's how the mechanisms of disease of COVID-19 takes place. And I hope I was able to deliver you in such a way that you could, as a layman, understand it. And as a medical personnel, like a student or a medical professional, I wish that my discussion there was able to bring out good concepts there, probably ideas for research as well. So there are references, and I wish that you should be able to, on your own, take a look at this. Thank you very much.
Thank you very much, Dr. Fidel, for very insightful talk. And you have used very simple words in order to make sure that everyone understands, not only the people who are in, in the medical profession, but the others can also correlate what happens during the process of this infection and how the tissues and the particularly the lung tissue is damaged by this infection. So Dr. Fidel will now take some questions from the audience. If you have any questions, please post your questions. So in the meantime, while you are thinking of posting some questions, maybe Dr. Fidel, is there, have they yet found any intermediate host for this infection?
Yeah, thank you for the nice introduction, and thank you, Dr. Farsana, and to the rest of those who have listened. Thank you for being so patient to my discussion. Okay, so intermediate host, Dr. Farsana, they have associated vector about vectors, and we have identified several animal vectors or zoonotic vectors, and very much implicated were pangolins and bats, but most of the studies have disproven the possibility of the bats, and they are more towards the pangolin type of vector. But what concerns us more at this point in time is the transmission, a human to human transmission.
Yes.
And I think it's so relevant for us to be able to understand how the virus transmits to another person, because we have currently been awakened up by the presence of different variants, and the variants have been associated with transmissibility. So I guess that's the area of where we can gather some more information in terms of ideas of research.
Yeah, this is what I was about to ask, and if you could shed some light about the variants, because so many variants have been coming, and they have increased the infectivity of the virus. So so you mentioned about hyaline membrane. Maybe some we understand what does it mean, but could you elaborate a little bit about hyaline membrane making in the alveoli or in the air spaces? So what does this membrane like tissue contain? What does it contain? How does it form?
Okay, thank you for that question again, Dr. Farsana. Okay, the progress of the pathology of the disease or the disease mechanism starts with the inflammatory response, and the inflammatory response is progressive. It starts from slow, moderate to fast pace, depending on the amount of infectious agent, because as the viruses multiply, for each and every release of the virus, they also kill the cells. And so more viruses, more tissue damage. Now, the more tissue damage, the seepage of the products of inflammation, which is number one, is exudation of fluid. So you see, the exudate, it's not like the type of pneumonia we know, such as lobar and bronchopneumonia, where we have a very a pyogenic organism. What the organisms involved in lobar and bronchopneumonia are pyogenic bacteria, meaning pus forming. And so what happens during these types of pneumonia is that when the infection sets in, the exudate rapidly fills up the alveolar spaces. The exudates in this type of pneumonias, bacterial pneumonias, they fill up immediately the air sacs. And so we have obliteration of the air sacs at very early stage in the disease. In a viral pneumonia, the exudate is not that fast. So it first goes out and lines, it sticks on the lining of the alveolar walls, and that's what we call hyaline membrane. And it's thick because it contains a lot of protein. And this is one of the reasons that, complicates the exchange of gases, because the widening alone of the alveolar walls would already hinder the exchange of gases. Then there's another thing. It's the accumulation of exudates that attach to the walls of the alveolars of the alveoli, and it creates more block of the oxygen exchange. So that's but then again, it's progressive. It's progressive because later in the course of the disease, if you have noticed the actual autopsy findings in the lungs, you see that it also been filled up. When the progress of the inflammation goes through, it also fills up the alveolar spaces, and then consolidation sets in.
Thank you, Dr. Fidel. There are a few questions on Slido. Question one is organization of interstitial pneumonia the same as consolidation?
Yes, organization is otherwise known as consolidation. So it's consolidation means the organization of the exudate, it's solidification. As I mentioned to you a while ago, if you have seen, I've done a few cases of autopsies long time ago. And what we see in autopsy cases of pneumonias, during consolidation stage, they actually look like gelatin. So the ones that are inside of the alveolar sacs are like gelatin. If you're familiar with gelatin, it's like that. So that's what they call as consolidation. And it's because of the protein content.
Thank you, Dr. Fidel. One more question is, there are two more questions. What are COVID-19 virus variants?
Okay, that's a good question because it's practically very important to understand what variants are. Okay, now let me talk a little bit of immunology. So there's what we call as antigenic shift and antigenic drift. Okay, like for example, in COVID-1, okay, SARS-CoV-1, it has shifted to SARS-CoV-2, producing not a variant, but producing a strain. So SARS-CoV-1 is another strain of SARS-CoV. SARS-CoV-2 is another strain of SARS-CoV. It's 1 and 2. And as the study shows us that the difference between the two in structure is about 80%. That SARS-CoV-2 is 80% similar with SARS-CoV-1. Now, antigenic drift is another one. So it drifts a little bit, like in the changes in the configuration of the protein, such as the one that's in UK. I think there's a change in the shift in the protein, in the amino acid. It's in the level of the amino acid changing from one position to another, and that produces a variant. So they still are SARS-CoV-2 with a different, antigenic drift effect on the protein in the spike. And so that differs the variant from the strain. So there are several variants, and we expect that according to what I've read as early as maybe 2 months ago, February, March, December, they already have recorded about 4,000 mutations. And what these mutations are, they are actually drift. They have changed a lot. But then again, it has been so, they have promoted the variant that's in UK and in South Africa so much. But actually, there have been so many more variants already. That's about 4,000, maybe those who have been in surveillance. But there are so many more, there are so many countries with the coronavirus, and we just can't imagine how many mutations have undergone, this virus have undergone in total.
Thank you. There is 2 more questions. Is there any difference in pathological finding in patients infected with COVID-19 variants. Have you come across any study?
Okay. Well, I haven't really gone into the pathological changes. There are very few. There are very few autopsy cases. In the things that I've read about autopsy cases, I've only come across about 40 plus cases of autopsy. Why? The reason why, because most of these countries have already administered. They have gone into cremation of these patients, and autopsies are very hard to find this time. But anyway, I really don't believe that in the variants there would be changes in cases of severe cases of COVID-19. I don't think that there will be much difference between the severity of the disease that is produced in any of the variants. But we have noted that those who die, they die in the same way. I mean, there's multi-organ failure in just the same way. And the reason why is not because of the changes in variant, is because the immune system of the body has not been able to check out, and they give way.
This hyperinflammatory condition. Okay, yeah, one more question. Can you help to describe the pathophysiology of anosmia and loss of taste sensation in COVID patients?
Yeah, thank you. What I've noted is that anosmia and loss of sense of taste is very common, especially. And I'm not very sure about the variant because not all of these patients have experienced anosmia and the taste differences. But then again, we can think of the effects of this in the neurologic level. In neurology, they affect the sense of smell and the sense of taste in the same manner. And the reason why is because of its affection on the receptors. You see, the olfactory the olfactory nerve endings also are involved, or are supplied by capillaries. And because the capillaries contain all of capillary endothelial cells contain this ACE2 receptors. And once these ACE2 receptors are involved, they damage the endothelial cells and they would produce some sort of inflammation there. And the changes in inflammation would be able to secondarily affect all these kinds of cells. There would be cellular degeneration in the olfactory nerves and, of course, in especially of the cranial nerves. And so this would explain a lot of manifestations. Actually, it's not limited to this because we have seen cases of central nervous system involvement, spine involvement, peripheral nerve involvement. And I guess this is just part of how the cytokines produce, because they are non-specific, they are generalized. They could affect the body in the same way.
Yeah, one more question has come.
Dr. Farzana,
yes.
Before we go,
yes.
Before we go to the next question, we can take next question. Just a soft reminder to all the audience to do a quick feedback. The Google Doc we have just pasted in the chat box. So by the time before we end, everyone can just give us the feedback for our ICON-MEGOPIC 2021 conference.
So from here, we have to join back to the main.
After this. But before that, before you go for the closing ceremony, can you just give a quick feedback? The Google Doc is there in the chat box now.
Yeah.
So, okay, sorry for disturbing, but continue, Dr.
It's all right. Thank you. Thank you, Dr. Imam. So one last question, Dr. Fidel. Is there any chances for the vaccination to be ineffective due to constant change in the virus configuration?
Yeah, this is a very hot
this is the hot topic of today.
It's very hot.
How these variants, may affect the vaccination, effectiveness of vaccination.
I have my own opinion, but let me be very objective in answering this question. It can be yes and no, because the variants, it's true, the disease is actually very, we cannot unpredictable disease. And so, we could have an immunity, but then again, we may say that variants could vary. Variants could also have a difference in the amount of how much change that it happens, especially in the spike protein, because all of our vaccines are based on the spike protein. There are some that are also based on subunit proteins, but then most of these, in general, the vaccines that are administered all over are about the spike protein. And the variants affect the spikes. So basically it depends on how much change does this spike protein have in each and every mutation that takes place. So hard to say a definite answer with that, Dr. Farzana.
Thank you so much, Dr. Fidel. A big thank you to your excellent, interactive interaction and talk, and giving us, so many answers to all the audience who were interested to know a lot about COVID-19, of course. So the COVID-19 pandemic, of course, all of you know this, that it has caused tremendous loss of human life in the world, and it continues to present and it will continue to present as a huge challenge to the public health and also, of course, food systems and the world of work, for quite some time. And the impact will take a lot of time to go away. So with this, we come to the end of the series of talks on Channel 3. So once again, I would like to thank all of you, including the invited speakers, the presenters, organizing technical team, and most importantly, our audience for their presence, patience, interaction, and participation. Thank you and have a very good day.
Dr. Farzana,
yes.
Can I, before we end,
yes.
Once again, I like to take the opportunity to thanks, especially our speakers for the day, Dr. Badrul, Dr. Nadia, and Dr. Fidel, and thanks for giving your time. At the same time, our chairmen, Dr. Sarjan, Dr. Umesh, Dr. Farzana, thanks for giving your time for the chairmanship, and it was really entertaining, also the same knowledgeable and fruitful outcome. I think all have enjoyed this. So before we end, I just want to we take a photograph. Can I request everyone to on the camera, our speakers, our audience, just for memories, we can take a group photograph. So please, everyone. Zanhan?
Dr. Nadia.
Yes. Nadia is around.
Yeah.
Can we? So, Olivia, the speakers were around, so if possible, that will be good for. We give some time for others to on the possible. Okay, without taking much time, with the count of 3, we can tell ICON-MEGOPIC. MEGOPIC will be our theme. Okay, 1, 2, 3.
MEGOPIC.
Yeah, so it was really okay. So, and lastly, I just want to give there was some technical issues, sorry for that, but it was overall good. Thank you very much. So I like to request everyone now just to give your feedback in the feedback form link in the chat box, and at the same time our closing ceremony will be live on the channel 1, so kindly join channel 1. That's it. Thank you very much once again, everyone.
Thank you.
Thank you, everyone. Bye now.